Associate Director HealthScape is jointly organized by the students of ISB's two academic programs, the Advanced Management Program for Healthcare and the Postgraduate Program PGP, and is mentored by the Max Institute of Healthcare Management at ISB. ISB HealthScape was developed as a platform that could bring together innovative ideas and latest from healthcare to different stakeholders. This year, we are discussing the next generation models in healthcare and will look to dissect emerging models in care delivery, business models, innovation in private and public health, and its intersection. We will discuss how technology is driving healthcare in the modern age and opportunities that arise out of it. We have an excellent lineup of speakers today who will have interesting and stimulating perspectives on a varied lineup of topics. I'm certain you would all take back with you important learnings from the discussion, and we hope to hear your feedback too. Thank you all for joining in today at ISB HealthScape 2022. On that note, I would like to invite Sriram Chawali, a student of PGP program and president of the PGP Healthcare Club out of the Hyderabad campus, to formally introduce you all to our keynote speaker, Dr. Harish Pillai. Sriram, over to you, please.
Thank you, Soumya, for kind introduction. So I would like to take this opportunity to introduce Dr. Harish. So Dr. Harish, a doctor with exceptional leadership skills, is the CEO of Metro Pacific Hospital Holdings, MPHI, which is currently the largest chain of hospitals across the Philippines and is the leading provider of quality healthcare to the communities it serves. Dr. Harish was previously with Aster DM Healthcare India for 8 years and served as the CEO of Aster India since April 2018. Prior to Aster DM Healthcare, Dr. Harish was the CEO of Egypt's biggest private tertiary care hospital, As Al Salam International Hospital, Cairo, for over 7 years. Dr. Harish was one of the most influential leaders in the Indian healthcare industry. Dr. Harish Pillai is a member of Joint Commission International JCI Standards Advisory Panel and was closely associated with Federation of Indian Chambers of Commerce and Industry, FICCI, and Confederation of Indian Industry, CII, and also Association of Healthcare Providers of India, AHPI. With this, I pass it on to Dr. Harish for commencing the keynote speech for the event. We are super excited to hear from you, Dr. Harish.
Thank you, Soumya, Sriram, for inviting me to HealthScape 2022. As you mentioned, I feel like a gypsy. Been traveling quite a bit and gathering a lot of healthcare dust from across the world. So I would attempt to look at the crystal ball and shed some light on the topic what we have. Just let me know if you're able to see my screen.
Yes.
Is my screen visible?
Yes.
Thank you. So I will take about 20 minutes basically to give you a flavor on the next generation business model in healthcare, what we see as practitioners, in the front lines. So my agenda is basically four, starting off with reading tea leaves. In India, we're very fond of saying chai pe charcha. So it's a bit like chai pe charcha, but only thing is that look at not the dip, but look at the tea leaves inside and how look at it. And there are some interesting traditions from Asia. During my stint in the Middle East, especially in Egypt, we were very fond of Turkish coffee. So when you finish your cup of hot Turkish coffee, you look at the bottom and try to predict the future. So it's a bit like that. Open sesame is from Aladdin Caves thing. So in our case, we are really touching all the dots. And when we look at opportunities, there's some fascinating things happening around the world. So I hope to give you a flavor of that. Of course, new paradigms in the way we deliver healthcare to the consumer, and of course, shifting sands as we speak. So the first aspect is, like I said, chai pe charcha, or reading tea leaves. See, at the beginning of 2020, when the virus hit all of us, wherever we are in the world, we saw the world literally changing around us. We were cocooned cocooned wherever we were. We were completely disrupted from our lives the way we knew it. And all the way to 2022, we most of us, we struggle to remember that what really happened in the past 2 years. It's like as if 2 years of our lifetime has been just erased. And so many of these things on the slide is, some of it is sweet and some of it is sour. And we saw clearly in 20 reflect back, wisdom is a rear view. When we look at that, we see that there is so much of changes in behavior. And some of these changes in behavior of consumers have been consolidated or codified due to interventions. It could be regulatory interventions, technology interventions. So if you look at, the early part, if go back in 20, there's so much of panic around. People really didn't know what COVID-19 all was, whether it's to do, unfortunately, if you had COVID-19 at that point of time, we've run through the alphabet, right? Now we are in Omicron, or even Omicron stealth. That's what we refer to, the B12. But those days we were still at alpha, beta. We were going across that alphabetic soup. And I still remember that people were going to the retail pharmacies, buying off all the alcohol, hand sanitizers, the mask, and many shops were running out of essential supplies. So from that stage to the real, I would say, the take home of COVID-19 is that all of us have been quite forced to really look at investing in our own health or well-being, not just physical health. I think one clear offshoot from the past 2 years has been mental health. How do we preserve our sanity? That's just fundamental. And how do we conquer ourselves in terms of our mental or mind challenges? So that's something to do with transformation of consumer behavior. Awareness is again to do with that, like we talked about. It's not just that kind of very mean kind of a society where we really didn't bother much. It's like an eye-centric behavior to a bit more, I think, a bit more sensitive about the world around us, because COVID-19 has taught us that sometimes long-term, the long-term plans which we used to do pre-pandemic, I suppose that's just, it's not true anymore. I think many of us have become more philosophical, that live life to the maximum, like we say, live life king size. So I think that is something to do with holistic, and also to look at the community and the planet. Of course, e-commerce has been very pervasive, and whether it's to do with healthcare or retail, wherever it is. And if you have the technology bandwidth, societies have really leveraged and learned to skip across the physicality and the logistic bottlenecks which came up. And this is something here to stay. And it's also interesting that from 2022 to 2030, how the world around us is going to dramatically change, leveraging on the e-commerce bandwagon. Of course, workforce and ecosystem. So we all thought that how exactly are we going to get to a degree of normalcy where work is concerned? Then, of course, we discovered the power of Zoom, Skype, whatever we call it, but mostly in Zoom calls. And then this whole challenge of managing two-dimensional conversations, just staring a computer screen from dawn to dusk. Of course, now we are going into hybrid mode, now that many parts of the world, the Omicron challenge has petered down. So we're really looking at flexi work arrangement. But I do not know even today, if you ask me that will we go back to the work style of 2019, where all of us just forget this interim of COVID period and go back to the way it was. I do not know, because we realize that workers who are used to convenience of working from home, they may not abandon it fully. There is a lot of benefits of going back and socializing in the workplace. So all these aspects, I think, is something relevant to us. Of course, supply chain transformation, mitigating crisis. So this is something what I meant by sweet and sour, which is something which is very disruptive from our traditional mindset point of view. Looking at tech, many things we have seen, and one of the key factors, especially those of us in healthcare. I remember my clinical colleagues in India. We were actually trying to connect to Zoom calls with Chinese doctors who were fresh out of Wuhan to understand that what is this all about. We were looking at WHO updates or CDC updates on what is happening there. Then came the whole crisis in Western Europe, especially overflowing hospitals in Italy. We looked at challenges in the United Kingdom, in the US. So we are trying to absorb all that information. At that time, when there was all doom and gloom, nobody thought that we would really find a vaccine so soon, the COVID-19 vaccine. Nobody even imagined that there would be a range of drugs available for effective treatment or interventions of a COVID-affected patient in a hospital environment. The simple factor is that it became possible because of technology and the power of quantum computing, artificial intelligence. All these things have come into a great play. So if you look at the tech trends, right from AI to genomics to 3D printing to digital twins or 5G, these are all here to stay, and these are the big trends which we need to be aware of. Headline news, especially in the past 2 years, and I would say it started off even slightly before that. Of course, AI, I already mentioned, COVID-19, the vaccine itself. Many of us are more confident of starting air travel because we all have our jabs, we got our boosters. That's mainly because of the power of AI, machine learning, due to which the vaccine has been brought about. Internet of Things has really made connected care really possible. And one of the challenges where when workforce dislocation took place, especially your brain's trust, represented by senior clinical faculty, when they couldn't come into the workplace for a variety of reasons, that's when the advent of connected care came about. We also realized that when the hospital beds were completely overwhelmed and there were no beds available, we realized the importance of triaging and making the acuity classification, that all patients need not be admitted. We could have transit homes, intermediary care homes, and many of them home care. Omicron has been a fascinating lesson compared to Delta, where Omicron, bulk of it has been absolutely no admissions in hospitals, very little, and predominantly managed in home care. That's where Internet of Things come, where you have this ability to connect and have a real-time check on the health of your patient. So that's really played a key role. Telemedicine is passe in terms of being a generic, and of course, big data, analytics, all have become a pretty critical thing. I mean, look at this this specific thing, like the amount of interest, whether it's venture capitalists, mostly venture capitalists, a lot of seed funding has taken place. A lot of endowment funding has gone into it. Even PE funding has gone into this entire ecosystem. Whether it's to do with AI, like I talked about, IoT, telemedicine, big data analytics, whether it's genomics, 3D printing, there's a dime a dozen big names associated with these phenomena around the world. So I think this is something good, and it's just accelerating, it in the real time what we speak. So one of the key factors due to COVID-19 is this whole phenomenon of fight and flight. We talked about the uptake on teleconsultations. Some of us we were very skeptical. What could be the adoption rate of senior clinicians who we thought that they already have a challenge even adapting to a basic electronic medical record in an integrated care environment? Would they be really comfortable to continue care for their patients using teleconsultation? But we were all proven wrong. Doctors were pretty fast and quick in adopting technology. Even if you don't have a terrific dedicated boutique platform, people used all kinds of things, WhatsApp, Viber, Skype, all kinds of channels to reach out to their patients. So that has been a lesson throughout the world. Of course, if you look at molecular diagnostic was rather exotic pre-COVID-19. It was pretty difficult to convince a hospital operator to make that kind of leap of faith to invest capital in setting up a molecular diagnostic lab in a hospital. But look at what RT-PCR has done. Now, RT-PCR is as good as Xerox for photocopying, right? It's become commoditized. So that's where these kind of trends have made some technology interventions so common and as part of the common man's lexicon. Of course, targeted drug delivery systems, I talked about that before, in terms of effective interventions to make the disease a bit more less lethal and remove that sense of fear even from the care providers, that they will really be able to do something positive for their patients. I think one of the other key lessons from COVID-19 is the real power of big data, analytics, and this kind of technology tools to manage crisis situations, which is like a force majeure, like beyond our control. I am rather optimistic that the next pandemic, which will happen, I'm just praying it's not in our lifetime, but it's bound to happen. We will have a much bigger and effective toolkit to manage crisis at that point of time. One important from a tea leaf reading perspective is that the world is more into personalized care, precision medicine. Colleagues in India, you all are used to the traditions of Ayurveda. Ayurveda basically is tailor-made for one person. So when you go to an Ayurvedic practitioner, they examine you, and whatever solutions they prescribe, it's not effective for a second person. It's unique to you. Modern medicine took a couple of decades to reach what Ayurveda has reached 5,000 years back, but it's really here to stay. So when we talk about, especially in field of immunology or rheumatology, or in terms of oncology, genomics has, and also immune modulation therapies have really made this personalized care quite important. But in the technology sphere, whatever we create, the ecosystem really have to answer to the basic needs of the consumer. So today we are talking about a person in the comfort of his or her home, who needs to access quality care, which is delivered in a safe, but could be a virtual practice, connected with the channels of the let's say e-platforms, whether it's e-diagnostics or e-pharmacy, to ensure that care is provided in a sustained and a holistic manner. So this is something which we really need to watch out for. One interesting aspect is that this is also slightly before the pandemic, but also very relevant right now, that wellness has become a massive global opportunity. It's much more. That's what it's interesting. Look at its size compared to pharma. Earlier, we would say that the big bucks were only there in the pharmaceutical industry. But now the whole wellness space, whether it's to do with physical wellness, whether it's to do with mental wellness, whether it's to do with dietary habits, whether it's to do with sleep, there are many facets of wellness. So that is it's a very interesting trend, and a lot of energy, time, and money is flowing into this field. Of course, from a basic construct point of view, the big shift is from a provider space, that we can see the world is really moving from the traditional brick and mortar to brick and click. The comparisons are relatively simple, that you need to have capital invested in physical infra. It's not flexible. It requires enormous kind of overheads, and is geocentric in the sense that it's very inconvenient for the consumer, that it is necessary for the consumer to actually travel to this physical entity to access care. So here we are moving not into a pure virtual or a click model, but really what would happen is a hybrid approach, is brick and click, which is future proof. It's bound to grow immensely. The overheads are much lower. It's very flexible. It's scalable, and is geo agnostic. It doesn't really matter where the consumer is present, and it augments the availability of scarce resources, especially in subspecialty practices. And in certain areas where pattern recognition is prevalent, whether it's pathology, dermatology, for example, or imaging, this is something which is already vogue and acting as a force multiplier. The next session is to just give you a glimpse of massive economic impact. That's what I call as eruption. This specific trend is to do with India, where we are talking about an economic opportunity of almost 372 billion US dollars in terms of job creation of around 2.7 million new jobs. You have massive amount of startups really accelerating, and India is also being called as a startup capital of the world. And it's exciting that the amount of unicorns which are coming up, and we will witness for sure in the next couple of years, unicorns coming up in the healthcare space itself. So I think that's exciting time. And due to COVID, and this is something, it's a bit embarrassing, but at least we can say that public expenditure towards this vital aspect, vital pillar of stability in society is here to stay. And I'm also glad that the common citizen realizes that they need to ask their political masters to ensure that adequate funding is available for the public healthcare space. So this is definitely a big trend which is there to see. Around the world, if you look at venture capital in areas such as digital care or remote monitoring and wearables, which I mentioned slightly before, clinical decision support systems or digital therapeutics or patient recruitments, even the clinical trials, which is a very challenging field. There is a lot of focus, a lot of money is being put into these areas. So I think these trends are just going to climb in the coming years. This is specifically a lesson from North America and the United States. You can see that in terms of accelerated EBITDA or your P&L performance, whether it's to do with virtual care, data analytics, a lot of money is getting sucked in, and they are really performing quite well to bring about operational and clinical efficiency in those areas. One other big chunk, again, due to COVID-19 and the past 2 years, it is really short of around the world is home care, mainly attributed to changing disease trends, aging of population, chronic disease management, and of course, reliable connectivity. So this is something which we need to watch out. It's a massive opportunity. A lot of innovations will happen. And this is an area where we find that traditional brick and mortar structures and brick and click models really offering seamless connectivity. Because if you look at an episodic encounter in an acute care space, post-discharge continuum of care can be extended in the comfort of your home. So that is also here to stay. Some new paradigms, like I talked about before, the individual and the person is pretty important. And from a consumer point of view, some of the aspects is, of course, accessibility to the care provider, whether it's to do with mental anxiety or physical anxiety. You need to have the real-time access to your doctor, which is honestly a bit of a challenge because we don't have that amount of doctors available for 24/7 virtual consultation. So that's also a scope for innovation in terms of HR practices, whether in terms of deployment of bots. So that's an area, but at the end of the day, that's what the consumer is demanding. Of course, the ease of use is very important, especially let's say someone who's in a pre-diabetic stage would like to preferably reverse it and go back into the proper wellness stage. So you need to continuously keep track of your blood chemistry, the correlation between blood chemistry, your dietary regime, your physical activity. So the ability for a system to keep track and aid change in lifestyle choices is something very important. And that leads to personalized care. That's what I mentioned, that the precision and personalized care is something which is expected from a consumer. And of course, long-term outcomes. In a simple way, how would I explain this? Like the old saying, an apple a day keeps the doctor away. I think the whole motivation for a common man is to stay away from doctors and stay away from hospitals with the help of technology. Eye care, again, on the similar principles. If you look at that entire ecosystem being created, whether it's to do with what I talked about before, the integrated ecosystem which connects, let's say, virtual care to home care, to chronic disease care, to post-discharge continuum of care, to acute care. So all this thing could be in the sickness space to wellness. So that is what I call as a 360-degree approach and expectations. Of course, ability to continuously track, like, I use an iWatch, somebody else might use something else. So much of data is being collected on your day-to-day physiological aspects. But are we able to make sense of it? Now, it's very different from what your watch tells you compared to an expert which has got access to much more information, experiential information. So that is something which is also expected. Then, of course, the connectivity options of the whole brick and mortar ecosystem, whether it's in the retail space or in the traditional space, of how the consumer's life can be made better. Innovations in the payment mechanism. Now, this is something where fintech is playing a key role to push the boundaries. Also, what fintech is doing is to increase accessibility to healthcare. So this is also quite fascinating. Analytics is going to play a key role also in a traditional hospital setup, that doctors have limited time. So can data captured even offsite, can that data can it be templatized in terms of your actual history, presenting history, your presenting complaint, systemic examination, general examination, systemic examination, and a differential diagnosis? even before you actually met the doctor. Can the system really help that? So that it's basically augmenting the ability of the doctor to arrive and to leverage on time, because time, I suppose, is the most precious asset nowadays for the clinician. So that's one thing. Also, from a population health management point of view, in India's case, the amount of data created by Ayushman Bharat consumption patterns across the subcontinent, can the policymakers, now looking at the data, target policy interventions in terms of preventive care to those districts where you find a certain consumption pattern of curative medicine? Now, that is something which I'm quite sure policy planners can really look at. And of course, risk assessment, fraud prevention, because another offtake from COVID-19 is the massive uptake on personalized health insurance policies. And we also know that successful insurance companies, in order to reduce the claims ratios, also investing in AI tools. We saw the big impact again to do with lack of enough number of radiologists of what AI can do for faster diagnosis using HRCT for COVID-19. That's already there. One new paradigm which I really forecast in the next couple of years is the intelligent robots. Right now, the robotic systems in place, the slave master robot, especially personified by the Da Vinci system. But imagine an intelligent being like an IBM Watson with that kind of ability for cognitive awareness is married onto an IBM on a Da Vinci. And then you create a bionic surgeon which is capable of autonomous function. So yeah, we are in the world of science fiction. And like Arthur C. Clarke, imagine one day about communication satellite. He never, in his time, communication satellite was something, a figment of his imagination. But here for us, it's a day-to-day thing. So I'm predicting that this is also bound to happen. Thor's hammer, I've mentioned before, of the power of machine learning, quantum computing, and artificial intelligence to push the boundaries of mankind, especially care providers, for treatment of COVID-19. Now, in silico medicine is a classical example of an AI tool which looked at all possible drug therapeutic agents which are available and advised clinicians that what would be more effective in the treatment of COVID-19. Flinders University is an Australian example where they partnered with a US agency to look at the first trial of a COVID-19 vaccine. So again to do with the technologies what I spoke about. Shifting sands, looking at crystal ball, looking at what pharmaceutical industry is doing. I think one headline news from pharma as a trend in terms of disruptive business models is the whole aspect of RNA therapeutics. When we talk about RNA therapeutics, of course, the sexiness of this field is because of the mRNA vaccines, whether we talk about Moderna or Pfizer. I mean, these are already proven their wares in many parts of the world. But there are also many other areas, whether it's to do with immune therapy, oncology spaces, where RNA therapeutics is opening up a totally new frontier. So many disease challenges, the way we know it today, might not be the challenge tomorrow. So that's something interesting for us to watch out for a trend. Of course, common lexicon areas, whether it's genome sequencing, miniaturizing using nano robots for interventions where you don't really need to even do keyhole surgery. Now, that is something which we are looking at. There's a lot of interest in that. So the key aspect is that whatever is happening will improve accessibility, increase affordability, and yes, give a certain minimum quality of care around the world. In terms of data analytics and clinical information system, the rate of innovation is anything to do with patient engagement, direct impact to the consumer. It's completely patient-centered. It can also be population-centered. This is an area where a lot of interest is happening. We can also see, like I talked about, decision support systems in a care provider environment. We can see areas of utilization management. So these are the areas where we find a lot of interest. Of course, the big brands, what we are always familiar with, that's what I call the march of health bots. Everyone, whether it's Apple, Microsoft, Android, Amazon, they've all invested more away from their traditional focus of their industry to healthcare space. So this is something which is there to stay. And also when you look at from a capability system build-up, other players have also matched up. So everyone is on the healthcare bandwagon because that's where consumer interests are falling, and that's where money is also there to be made from an industrial and a business point of view. This is my last slide. So when we look at Homestretch, I talked about the scenes from North America. Look at the space in India. It's very exciting. From a Homestretch point of view, dime a dozen players have emerged, which is really contributing to, I would say, it's like a bubbling kind of a thing. It's fervent, it's bubbling, it's energetic. And this is going to be a new game changer, and hopefully will take India to a pole position. And overall, I can see, I'm based in Manila in the Philippines. I can see from my position what's happening in Asia in the near term. So I think Asia is a place to watch out for its contribution in the healthcare space. Yeah, thank you so much.
Thank you. Thanks a lot, Dr. Harish, for the wonderful talk, especially the tea leaf reading perspective, chai pe charcha, about the sweet and sour lessons from COVID-19 and the tech trends of post-pandemic world. I really like the concept of brick to click and how powerful the model is. Thank you very much for joining us. I would also like to take this opportunity to thank Professor Sarang for joining us today. Professor Sarang is the Executive Director of Max Institute of Healthcare Management. He's the Professor and Area Leader, Operations Management at ISB. We look forward to your closing remarks later in the evening, Prof. Thank you. Now I pass it on to Dr. Nipun Nagpal, my counterpart, who is also a PGP student from cohort 22. He's the President of Healthcare Club at ISB Mohali campus. I would invite him for the first panel discussion of the day, technology-led models in healthcare. Over to you, Nipun.
Right. Thank you, Shriram. Good afternoon, everybody. It is my pleasure to introduce you the esteemed panelists and the moderator for the first panel discussion of the day. The first panelist, technology-led models in healthcare. And our first panelist of the day is Jayashri Kanther Patodi. She is an ISB alum and the co-founder and partner of Enzia Ventures. Enzia Ventures is a purpose-built venture capital fund focusing on investing in early-age companies in healthcare, education, and environment. Next, we have Mr. Randeep Singh. He is the co-founder and CSO of Meadow Doxper. Meadow Doxper aims to develop 360-degree solutions to digitize the entire patient journey involving all stakeholders in the healthcare system. And finally, we have Dr. Ashwini Kumar Setia. He is a senior gastroenterologist and medico-legal consultant. He is also the General Secretary and Trustee of Medico's Legal Action Group, a non-profit organization engaging the government on various legal and regulatory issues relating to healthcare providers. Our moderator for this session is Professor Madhu Vishwanathan. He is the Senior Assistant Professor at ISB in Marketing, and he is the Research Director of the ISB Institute of Data Science. Welcome everybody, and over to you, Professor.
Thanks, Nipun. Can everybody hear me?
Yes. Yes.
Thanks. And, we had a wonderful talk just before this panel. And I think what the panel is going to do is dig deeper into some of these technologies and the solution. I do concur with what the speaker just before us said, that it is an exciting space. And there are lots of new technologies that are coming in, lots of disruptions that are going around. And I think we are going to see how healthcare is being delivered. Now, we are seeing a lot of increase in coverage and growing investments from both the government and private players. And what the pandemic in general has done is it has accelerated and possibly change consumer behaviors. It's not clear yet if it has changed consumer behaviors for the long term. But one of the biggest boosts that has happened during the pandemic has definitely been technology-enabled healthcare solutions. And we saw that in the many illustrations that the previous presenter had, right? In terms of remote care delivery, telemedicine, teleconsultation, and then integrating that with smart diagnostic apps. Now, in this world, one can actually think in terms of two business models. One where companies have a technology-first mindset. Okay, the Ubers of the world. So think of an Uberization of the healthcare. I'm not coming up with names on purpose here. Where they're looking to apply gains or benefits of technology in healthcare. So you can think in terms of integrated care ecosystems, platforms, patient engagement, etc. So that's one way of thinking about a technology-led business model. The other one is a healthcare setup where it's a traditionally healthcare-based company, a healthcare-first mindset, and whose primary goal in general is to improve healthcare access with the aid of technology. So think about, let's say, adoption of EMR systems, adoption of new technology innovations in detection and scanning and so on. In this panel, what we're going to focus on is the first, essentially technology-led businesses. And as a new kid on the block, I think they have the immense potential to disrupt existing offerings. They come from a very different perspective. But this could potentially be good or bad to society and consumers. There could be some people who benefit and some people who lose out. They could help alleviate our overburdened healthcare systems, but they can also bring in new risks in terms of consumer privacy and regulations. And so what we have with us is a great panel who's going to talk, in general about what it is about technology-led business models. So the lay of the land, if you want. We're going to talk about the potential good and potential it has in transforming the healthcare delivery systems. We're of course going to talk about the pitfalls of these systems, things that we should be wary about, the challenges that people face, and of course the way forward. The discussion that I have set is structured as follows. We will give the panel roughly around an hour to discuss these topics, after which I will open up the floor for questions from the audience. Okay, so this is essentially how the panel is set up. And then the discussions are set. So let's start with hearing from the panel first on what they think about the topic at hand, right? So this is about technology-led business models in healthcare. Randeep, do you want to start first? And then we'll go around the panelists. You're on mute. Yeah, now you're good.
Good afternoon, everyone. And thanks to the organizers for having me in the panel. So I'm one of the co-founders of the company. Doxper is like, I think most of the large hospital individual doctors are aware of that. And in this panel, I think if you look at the topics like technology-led business models in healthcare, the keywords, of course, is technology, then is the business models, and of course, what positive change we can bring to healthcare. And if you look at industries, healthcare is one of the industry where technology always has tough time. So, I mean, of course, the doctors use WhatsApp, all those things, but if you look at our IT infrastructure, the EMRs or the HIS, they're probably like 10 years behind in the UI UX, or how do you interact with the system, how do you capture the data, how do you want to see the patients, right? Of course, the reason being certain industries such as healthcare are also very highly regulated. So what has been running for a while, it's very difficult to change in less number of years. So this is one. And of course, there are structural baggage which we have. I mean, see, doctors, they have biology till very long time, but they have maths only, let's say, till class 10. So we are already separating the divisions. And of course, there are few exceptions, like very genius doctors who can understand each and everything, right? And of course, there are engineers who are more tech savvy. They understand how the devices work, gadgets work. So I'm just listing down certain things. And of course, any technology which comes to the market needs to have a value proposition and how we are solving the problem. And of course, you need a sustainable business model to grow that company. And in the end, it needs to help majority of the stakeholders in the whole healthcare ecosystem. So I'm talking about the patients, the providers, the insurance companies, or the policymakers, or the pharma, right? So essentially, the whole onus falls back onto the data, which can do a lot of things in the ecosystem. And there has been a lot of ideas in kind of capturing this data and the other ecosystem to unlock. So I would definitely want to highlight the ABDM. I think the government's initiative for the digitization of healthcare. So it's been close to 3 years, and I think only this year they have opened it for across India. So I'm very bullish on that. And of course, what is going to get in the future is a newer kind of business models, newer kind of companies coming in. And our journey may be completely different from how Western economies have digitized their healthcare. Yeah, I'll just take a pause here. Yeah.
Jayashree, do you want to go next?
Yes, happy to. NZI is one of the few VCs which has health as one of the major focus areas of investments. So that itself speaks about the potential that we see in technology-led businesses, and hence investing our money behind it and our investors' money behind it as well. The reason we are bullish about it is, I'll break it up into two parts. One is just personal experience. In 2016 to 18, when I worked with one of the largest hospital chains in Asia, I could see where India is versus where even some of the hospitals in Singapore, Turkey were. Right? Leave apart US, which is much more developed and a very different regulatory regime. But even in the neighborhood, one could see that the adoption of technology in Indian healthcare was significantly lesser as compared to neighboring countries. And that was definitely one data point to say, hey, in the coming decade, either we adopt or we get disrupted as healthcare providers by the startups, right? So that was really the genesis to kind of make a personal segue into this early stage startup health environment. And I think on the macro side, very bullish because of three main reasons. One is, I think consumers, patients have now seen the power of technology. And Professor Madhu, like you were saying, Uberization, right? I would use that to say, even in a cab, before taking the cab, you now know the estimated time and price, right? Why not in healthcare? Like, at least some estimation. There is obviously a margin of plus minus, but why not use AI to empower the consumer with that knowledge, right? So there's definitely been a strong push from patients and consumers, even before COVID, to say, why can't I book an appointment online? Why do I have to wait in long queues? So I think that was already there, and a strong force for sure. The other two reasons that we see now is, one is the quality of founding teams that are jumping into the startups, right? A lot of founders are now seeing, hey, we've done a lot in the travel, hotel, food, but health is one really untapped space. People are realizing both from personal experience as well as from a wide area of opportunity. So what we're seeing, and being investing in healthcare since 2008, both me and my partners, we are definitely seeing a sea change in the quality of founders. The founding teams now not only bring healthcare experience, but also technology, different team members. So just bringing in the right blend of experience that is required to navigate the relatively complex world of healthcare as compared to any other subsegments, right? Because it's just multiple stakeholders with different behaviors. And just having a nuanced understanding of that helps you think through your business models much more sharply versus just trying to copy paste from another country or from another segment. So that is definitely the second one. And the third one, thanks to COVID, all other stakeholders who were a bit skeptical were forced to adopt, appreciate, and hence now be open to adopting. And I do believe, healthcare is one of those spaces which will be, the phygital models will really kind of work. Starting with, of course, there is a way you kind of start different businesses, but yeah. So I think thanks to COVID, that's a positive side of COVID, I would say, an acceleration where now technology can be truly utilized, and we can overcome this significant shortage in the specialized doctors to patient ratio, right? And bring healthcare to all. So I'll just pause here and take up.
Thanks, Rishi. You picked up on some themes which are close to my heart, which is getting wait time at the doctors. It always irritates me as a marketer to know that you can't give me a proper time, even within a space of few hours, right? most people in India, there's strong research to show that most people in India avoid going to the doctor because of the uncertainty associated with, just having a visit to the doctor. And, anything we can do to take care of softer things, which is not necessarily hospital related, could go a long way. I will pause. I think we are getting ready for a very interesting conversation on this. For Dr. Ashwini Kumar to pitch in with his thoughts on, what he believes in this space.
Hi, everybody, and I must thank ISB and Nipun for inviting me to this panel discussion. Let me just sound first a disclaimer that I don't want to be a naysayer or a cynic, but I would definitely like to be a devil's advocate. Dr. Harish Pillai in his opening remarks mentioned that the senior doctors are a little wary of using the technology. And he was not very much off the mark. We are adapting to it. But yes, say for example, just before the start of this panel, I pinged Nipun that, listen, I do not know how to use the ISB background. And he finally gave up, seeing that, okay, do this. And I said, okay, that plus sign is not responding. So, we are going to learn. Our fingers are now rickety, not really typing as much, although now the dictaphones, etc., are there. You can do that. That brings me to first introducing myself in a little different way. I'm also a program director of postdoctoral education program in Max Institute of Medical Excellence, because this is associated with Max. I thought I'll tell you. Now, what I see in this zone is that the medical education and the digitization of that has not been emphasized. And I think that's a big business opportunity. Webinars are a galore. In fact, nowadays we say that, okay, are you having a webinaritis? Because there's so many webinars, so much of education material, etc., that I think that can be really, really exploited, and it is being exploited. Coming to our main theme is tech models from physical to digital. Now, here I would say that my Bible of medicine, every single book, the first page writes, even the latest edition, there is no substitute for a good history and a detailed, thorough physical examination. That cannot be compromised under any circumstances. Now, see, as with life, which we deal with every single moment of our professional life, the technology also evolves. We have seen that on olden days, when one would have had to have a cataract surgery, you would have had to go to a doctor and you would have had that green patches or sunglasses for 14, 15 days and not moving this, that, and the hair. To cut the long story short here, today you go get a cataract surgery done. You don't have to wear those thick glasses. You have the implants of the lenses there, which is digitized. The power, the digital thing is there. So the business is there as far as devices are concerned, or pharmaceutical is concerned. And even the nano molecules, drugs, as Dr. Pillai had mentioned earlier, are there to be sort of delivered. Target delivery is there. Having said that, we are definitely looking at a very exciting era, especially as far as telemedicine is concerned. But not everything is hunky-dory everywhere. Telemedicine is regulated, although not completely yet, but is regulated with certain rules which are hard to follow. There are 4 lists of medications which you can prescribe on telemedicine, which cover nothing actually. And you can't even follow that up. Second, we will discuss it as we go by. As far as telemedicine is concerned, the liability for medical negligence is exactly the same as the normal physical in-person treatment of the patient. And you are likely to falter more during telemedicine because you do not examine the patient. Taking from here, the artificial intelligence is absolutely great. There's no doubt on that. We have used this in endoscopy. I'm a gastroenterologist and we use that in endoscopy. etc. But there is a potential of misuse, as is there with anything. For example, atomic energy is being misused, making bombs and making atomic energy and giving electricity and so many other things. So there's a misuse by the advertisers, also by the so-called aggregators now. Again, as we go by, we will discuss that. So my biggest fear and to some extent objection is that as digitization advances, as it progresses, we are dehumanizing medicine because we have commoditized every single thing. Everything is a product now. The doctors are being commoditized. So, and the digital health, the digital technology is not really addressing so many other things like mental health. For example, a communication. There was a study from UK which says, anecdote actually, that a robotic computer went and announced that your relative has passed away. Now, this is kind of unacceptable as far as that is concerned, because you cannot emote. An emotion and sentiment makes a great part of medical treatment. I rest here. Thank you very much.
Thanks, Dr. Kumar. You've raised a lot of issues, and we will get into that as the conversation proceeds. But I want to start with something very simple, right? How would you define a technology-led healthcare model as opposed to something which is a healthcare company using technology, right? And Jayashree, if you can pitch in, because you said you've seen a lot of these companies out there, especially in the last decade or so, right? What would be some of these key elements that these are tech first companies, right? Because you're talking about how they've seen different areas and now they're saying, okay, I see possibility for disruption in healthcare. So how do you think, what would be examples, or how do you think about these companies? What would define them?
Yeah, that's a very interesting question. I'll use the example of what I've seen in hospitals. And when they think about, I think the journey's evolved a lot from, let's say, 2016, 18 to now, over the 4 years. But just to paint that picture, right? When people are adopting technology in existing businesses, to begin with, they're just thinking very simple things of digitizing hard copies, digitizing parts of the processes, right? The radiology department is probably digitizing. But what was missing, and I do see a significant, many hospitals now adopting that, what was missing was integrating all of that from a patient perspective, right? Such that the end-to-end journey is integrated, and it's not like just parts of interactions are digitized. So that was definitely one challenge. And the reason I'm still a bit skeptical of whether all existing healthcare businesses will successfully adopt tech is because, one, they have their own challenges. Most hospitals in India, if you see their return on invested capital, it's not very attractive. And hence there's a lot of pressure just on making the existing business much more financially viable, right? And hence there are already top of mind priorities. And hence the leadership is not able to see digitization and technology as the topmost challenge, right? So I definitely see that as a challenge, and hence I see the opportunity for the new age founders to think technology first and to almost build it from scratch, right? I met Randeep during my earlier journeys of 2016-18, and when I was saying, one of the triggers was the quality of founders. It was founders like Randeep also who had seen healthcare, who were bringing different talent together. Of course, healthcare is a long journey, and you won't see like some other sectors, whether it's consumer or education. You need relatively much more patience to build healthcare models. But today, I would bet on the new age startups really truly adopting tech versus existing businesses adopting tech, and kind of I do see significant challenges in the latter in terms of mindsets and people.
Yeah. Randeep, do you want to pitch in?
Yes, I was just waiting for Jayashree to finish. So yeah, so I will say what I've learned over whatever my 15, 16 years in healthcare, right? I think the processes which have been set, the workflows, including like the normal regular workflows and the clinical workflows, right? I mean, they cannot be standardized. So I mean, think of other things. You want to book a ticket for a plane. You know exactly there are 4 or 5 factors, and you know these factors, and you can book a ticket, right? I think one of the panel, I think Jayashree only saying, okay, somebody wants to get a surgery done, right? Why can't they give me at least an estimate within plus minus 1 lakh rupees that this is what is going to cost, right? Now, of course, what are the comorbidities of that patient, right? If he has a medical history, if other things, did he have the surgery before? How complex is the patient? I mean, you don't even know what are the factors you need to consider to make a AI-led model, right? I mean, so the reason Dr. Watson failed, yeah, of course, I mean, they might claim it is success, but it's not, because the human reasoning of what happens is in healthcare, you are discovering new things as you go along, right? I mean, you don't have a very clean data set. Of course, people assume that since we have solved the problem of chess, given enough data, we can solve any problem. That's not true. So my take on that is, I think it depends upon a closed system or open system. A closed system is one where you know exactly if I change certain thing, what is the output. So if you have a model for a closed system, however large, the computer will always get a better solution. Right? In healthcare, we cannot model it. So the journey of the patients, you have data which is, I mean, it's not captured properly. It is not documented in a structured way. Of course, let alone that, if a patient goes to 3, 4 different hospitals, there is no way I can aggregate it. Of course, Jayashree is talking within one hospital itself, you cannot aggregate the data, but the patient journeys are complex. So he might have a surgery in one hospital, but his family doctor could be sitting elsewhere. He has his own clinic. Now, how do you combine all these data sets together so they can build models? Of course, one of thing I misunderstood was this is technology-led AI models in healthcare. So, I mean, that is like tougher thing, but business models, yes. I mean, even if you show certain value to the doctors, to the patients, to the hospitals, I think you will have a winner, right? And yeah, building on Jayashree's point, I think healthcare is full of problems, and full of problems, industry is also full of opportunities. So even if you solve big problems, each of these things can become big in, I mean, you can have different kind of startups just solving a very small problem, just like the internet companies do, right? I mean, you don't get a cab, let me just solve that problem. Yeah. And one point which I think is missing, and Jayashree, like people who have strong backgrounds in the domain, right? I mean, we need to be disease specific. This is, and of course, there are whole care cycles for the disease. I mean, how do you do the screening or the diagnostics, right? How do you cure or manage that disease? And once it's done, how do you kind of prevent from this recurring? So in the simple reasons of, I mean, I foresee that in few years' time, companies who can do screening faster for a certain disease, they can become like unicorns. Can I screen like 2-3 million patients in a day, right? Can I screen like cities? I mean, take one of the problems which was open during COVID was somehow you want to prioritize the vaccines for people having comorbidities. Now, nobody has a list of like which are the patients to prioritize depending upon the clinical history or the comorbidities of that patients. Yeah. So just take a pause here and let's continue. Yeah.
Yeah, Dr. Ashwini here, I'm sure has a different point of view. So over to you.
Yeah, no, I just wanted to actually comment on what Randeep said, that we cannot have standardized everything. And that's correct. That's true. Say, for example, even if you give a package, which has been in the work for quite some time now, that, okay, you give a package of these many rupees for that particular cesarean section or something. But remember, most hospitals, if not all, will give that package for that particular number of days of stay, right? I would like all of you to please recognize the fact and appreciate the fact that medicine is an inexact and imprecise science. It is a science, but is inexact, imprecise. Here, most often 2 plus 2 do not make 4. They make 3.5 or 5. And that is why you do not know what thing comes up when. Even life as such is very uncertain. Next 5 minutes, whether I'm going to have a heart attack, I don't know. Right? So that is the reason why this kind of standardization is not really possible, at least as far as the current level of understanding is concerned. I just wanted to make that point there.
I would just like to add one data point. Again, when we were working with IHH, so just drawing example from another part of Asia. So in Singapore, in Mount Elizabeth, they've been successful in the last 2 years to adopt AI and give 80 to 90% accuracy on bills. Right? So
Sorry?
I think 80 to 90% accuracy on the bill as estimations using AI. So a data point, and now they're kind of rolling out that same to other countries. But so I do think the perfect answer, and healthcare, of course, has variabilities. But I think from where we are today, we can definitely make incremental better steps, right? Like today, a lot of hospitals even keep medicines out of the packages, and which leads to a lot of uncertainty in the patient's estimate, right? So I do think, you can't go from 0 to 100 today, or let's say from 10 to 100. There's some financial estimates today itself, but you can definitely go from 10 to 60 using the power of the data that you have already, and hence the power of AI on it.
See, there is another thing. Sorry, Madhu, can I come in?
Yes, of course.
There is another thing which we must understand. We are in India, and as of now, we are addressing the problems or opportunities, challenges associated with modern medicine. That is allopathy, right? A vast number, if not majority, who are there in the rural areas, etc., are still treated by quacks, if not quacks, qualified Ayurvedic people, or homeopathy. Even in urban areas, homeopathy. Now, homeopathy is something which is probably, to my mind, I may be off the mark and wrong, to my mind, homeopathy is impossible to standardize, because for the same symptom, the drug may be different for you, Jayashree, Randeep, and myself, right? And therefore, it is difficult to have a standard. Say, for example, a particular disease requires a particular medication. In modern medicine, we know that every this kind of infection would require that kind of antibiotic. You may do digitization and do a target delivery to decrease the side effects, etc., etc. But what about that? Number one. Number two, treatment principles and philosophy of Ayurveda is completely different. They see what is your constitution, what kind of constitution aberration or derangement can give rise to that particular disease. See, so let's probably, because I know only modern medicine, therefore I am not competent enough to comment on that. But having said that, if we address only the modern medicine and only the urban population, although it may still make sense because of absolute numbers to make business models, but we must address those population segments also. That's what I'm saying.
So, let me put this discussion in a much smaller setup, okay? Because I see different themes flowing around here. One is, when we're talking about technology-led business models, I think Jayashree was very good in talking about, the integrated experience that defines a technology-led healthcare provider as opposed to a healthcare-led technology adopter, right? And the other one was about how starting from scratch for some of these setups might be better, maybe because of the institutional setup, maybe because of the costs of switching, legacy in terms of people adoption, and so on. Okay, so that's one summary, but we should be careful about where we are applying it. Okay, and this is where I'm going to make the distinctions. And I think we can think about technology-led business models doing two parts, right? Because of this complicated system. One could be just improvements in the business aspects of healthcare delivery, right? It could be customer engagement, it could be inventory management, it could be delivering certain things to people. And this could apply to a lot of places, right? Even in rural places, knowing, when you would need to stock certain medicines as opposed to not have some medicines, right? Figuring out what should be made available should be a very useful thing for communities as such to benefit from. On the other hand, I also see technology-led businesses, again, making an impact in terms of quality of care, right? Where there is affecting the doctor patient or the healthcare provider patient interaction with respect to the service provider, which would be healthcare itself. Okay, so I see this as two different dimensions. And again, I can understand the challenges or the questions regarding the second part, which is saying, okay, I'm used to seeing the doctor in person. I don't like to see him, over a Zoom call, right? But at the same time, I can see how, if I want to go to a hospital, you tell me you're going to see me in the next 2 hours, I can appreciate that. Even in a rural setup, right? And, going back to what Dr. Kumar was saying, I think there are examples in India now which are leveraging teleconsulting with not just going to a setup, but with, technical specialists who are able to kind of act as an intermediary between hospitals and the patients in rural areas, right? Having a trained nurse, a trained not ophthalmologist, but somebody who can help take your eye scans and then convert it to the doctor. So we are seeing lots of different models out there again. So how about we frame these discussions in these two setups and then talk about, let's say, potential in the first aspect, which would be non-clinical aspects of technology-led business models. And the second one would be the clinical aspects of technology-led models. Does that sound okay to the panel?
Yeah, I think, Manu, that's perfect. So, I think that's a fair division between clinical and non-clinical. Yeah, of course, doctors love doing the clinical part, and they are not very enthusiastic with doing the non-clinical part, right? So, of course, at Meadow, if you see, like, what we have been doing is after the doctor-patient consult, there are a lot of things the patient needs to do. Let's say get medicines, get like lab tests done, or get like scans done, right? So, of course, I think 80 to 90% of our healthcare in India is being delivered by facilities which have less than, I think, 5 doctors. Of course, the large corporate hospitals are many, but they are like, if you see population-wise, 80 to 90% or more of population gets served by facilities which have less than 5 doctors. And of course, they're like single doctor clinics or husband-wife clinic, which are many, right? Now, at Meadow, one of the technology which we have done is kind of streamline all the non-clinical operations, right? So we build models for the doctors, so what kind of patients come in different times of the year, and we optimize the stocking of the medicines, and we have tie-ups with all the neighborhood pharmacies or the labs and the scan centers as well, right? So everything, the patient gets the appointment in the clinic itself. So it's kind of a peace of mind. And this facility is availed by about 70 to 80% of patients in the clinic itself, right? So it's a one-stop solution. So yeah, so that's the non-clinical part. And of course, at DocSpur, I think the doctor-patient encounter and digitizing that. So that is what we have been doing. And of course, as Dr. Ashwini was saying, tough to type while seeing the patients in the eye. So we have a digital pen and paper solution. And this marriage between Meadow DocSpur is kind of growing very fast in order to solve the same problems. Yeah.
Thanks.
I would like to add one insight on the non-clinical, on the businesses which are focusing on the non-clinical parts, right? So when I started this journey, that was the trigger to start to say, hey, these hospitals, the way they're running, there's so much tech to adopt. I observed in startups, which are only just doing some of the non-clinical parts, it's difficult for them to scale meaningfully, to monetize meaningfully, right? Because all said and done, the cost of acquisition both from money as well as time perspective is very high. And also learning from other digital segments, right? Like consumer, till you go full stack. And I think, Randeep, you've evolved in your own journey as you evolved from Doxper to Meadow. So and also because I'm assuming in the audience, there will be a lot of people who are thinking startups, ideas. My one bit would be, you can't just think like some non-clinical processes. You have to think patient journey and fulfilling that patient journey end to end, because that's meaningful for the patient. And because you are meaningfully solving the problem, hence you can demand a meaningful chunk of the pie and be sustainable. Because otherwise the cost of acquiring the patient in this age today digitally is not cheap. And hence then a lot of those businesses are not able to scale meaningfully, and they remain as subscale services and not then meaningfully making a dent in the ecosystem. So just wanted to make that point on the non-clinical. On the clinical, there's a lot to share, but I'll pause on that for later.
Yeah, Dr. Kumar.
See, even non-clinical part, well, I completely agree that even in the rural setup now, for example, in COVID, etc., the telemedicine did wonders. At least it could save lot many lives just by giving the first aid, etc., etc. And those people who were not really clued to it were made to be there by their younger generation, etc., etc. Let's not go into that. Even the non-clinical part is eventually related to the clinical part. For example, if I have to keep a record. Now, digitization has helped me in more ways than one in definitely recalling that thing, making the data available, etc., and planning the further treatment of the patient, which many people do not get their old prescriptions in good old analog days when we used to write that. So they are also related to clinical part. But what I'm coming is, as far as startups are concerned, say, for example, the non-clinical things are peripherally related to clinical things, say radiology, say pathology, where there is image transmission. You can have multiple opinions. On a physical patient, it is difficult to have multiple opinions without human interaction. On the other hand, if the image is transmitted, you can have multiple opinions, and the best of the world, you can do that. And so that non-clinical, which is rather peripherally attached to clinical part, where there is no immediate human interaction, is a great thing that has come up. Similarly, you can transmit these images, even the endoscopic, real time, and plan for the treatment which is required immediately also. As far as the other data, etc., is concerned, say sending the non-clinical part, sending the prescription to the chemist for delivery, etc., that is also regulated by telemedicine guidelines. You have to have the consent of the patient. There are intertwined things. If I may be permitted to chip in here, as far as the aggregators are concerned. Now, there is a recent breed of people who are acting as aggregators like Ola and Ubers. They are getting the doctors, and as I mentioned in my opening remarks, that everything has been converted into a product. It has been a commoditized thing. For example, they say somebody types laparoscopy or somebody types cholecystectomy, and AI-aided thing suggests you that we will do the cheapest for you. Now, see, cheapest is something which attracts Indians like nothing else. And they do not know what the doctor is going to be, who the doctor is going to come, who is going to be liable for that, etc. Why? Because, see, I think, again, I may be pardoned for saying so or being off the mark, business ethics are different from medical ethics. See, you are looking at business ethics, whether it is legal, ethical or not. Medical ethics are completely different, where you have to give autonomy to the patient to decide about his own treatment. And digitization has led to, in some way, compelling you to accept one or the other solution. Thank you.
Or wrong perceptions, right? Just to, a sense of security or hope when there isn't any, and it's misleading at best, right? I think you're bringing up two good points. one is, I always in my class, I talk about the Indian consumer mindset being cheap and best. We want both, but somehow it gravitates more towards cheap, and best is, whatever is cheap in some ways. And the second thing that I wanted to touch upon is, you're right that a lot of times it's about framing of choices and how the information is presented out to consumers. And there is clearly a wrong perception. Like if you're just showing prices and price variations, people often confuse that to be signals of quality. And either they go with the highest pricing, it's high quality, or they might take the lowest price saying there's no difference in product, when in fact there might be. So you're raising some very good issues once it comes to the information. I want to dig deeper into the second part, which is essentially the clinical part of it, right? Which is where I think a lot of gains are there, because we all know that our healthcare system is overburdened. All these business things, yes, I think they will get us better, but I think it is the healthcare infrastructure could really benefit, and that is at least, for most optimists, that is where the real gains are. And like everybody has pointed out, there are immense challenges in that world, right? So can we talk a little bit about the challenges and, how people who are thinking from a technology perspective can navigate some of these?
Maybe I can
Yeah, go ahead.
On the opportunities in the clinical side of it, right? A few data points. One is if you look at the larger healthcare sector, and I'm also bringing in some VC perspective here, how we kind of look at opportunities within the clinical space, right? If you look at the larger healthcare space, more than 50% of the profit pool is from pharma. And the way the pharma industry works is they are very focused on specialities, right? So the way at least we think about businesses which could be successful is one, either which could really scale, addressing patient journeys meaningfully, or second, which could get acquired by existing healthcare players, right? And we definitely, when we think about clinical, we definitely see a huge area for specialty focused businesses, which could then get acquired by existing healthcare players. Because definitely in the coming decade, if the existing healthcare players want to retain their leadership in a certain specialty, they will end up acquiring the technology-led players in those spaces. Now, the second criteria, and Dr. Ashwini touched upon that, and extremely, extremely important is, whether the founders are bringing in the clinical outcomes focus approach first, right? And I think it's a very fair concern, Dr. Ashwini. A lot of businesses today are missing that. And I think that's a big red flag, because that's going to cost not just those startups, but the whole ecosystem very heavily. So I think that is definitely one area of deep diligence that we do when we are evaluating startups, whether the founders, the way they are thinking about the patient journey, the way they are thinking about the workflows, the clinical workflows, do they have clinical outcomes focused or not, right? And I think that's the only way we can build some of those long-lasting businesses. So that was the second point. And the third point is, of course, patients these days, chronic diseases are the ones which are growing much faster. A larger population is suffering from chronic diseases. And there the patient journeys are definitely broken. Because the super specialists are super busy, right? They do cater to the patients, but they don't have the time to handhold the patient on all the small queries that the more informed rare patients have today, right? So if there could be a true integration between technology, which is empowering the specialists to be more efficient, to have a view on the patient journey, I do think, those are some of the powerful business ideas that at least we are bullish about.
Okay. Dr. Ashwini, I'll switch to you before going to Randeep.
See, I would say that what are we talking about? We are talking about business where the pivot is the patient, right? Patients' problems have to be addressed. And the important stakeholders are business founders and the doctors. Problem to me, it appears, is that there is no coordination between all three at the time of development of business. Say, for example, okay, this is what you want to do, but the end user, that is a doctor, for a particular device or for a particular method of treatment is not consulted, right? Number one. Number two, what Jayashree was saying, that the doctors, specialists or super specialists, or for that matter anybody these days, is hardly having any time to handhold the patient. And I would take it as that they do not get to communicate what even they wish to because of lack of time or whatever, and how to make that efficient. My point is that we have to find out, we have to come together at a point where the communication is effective and not impersonal. Problem is that if you type something, give it in written that, okay, read this and then sign. The patient, you see, remember one thing, the patient is not a normal person walking on the street. He is suffering from some disease and he is mostly down, out and low. Therefore, it requires a personal interaction, which is where my fear and my apprehension emanates from.
Right. Randeep, any thoughts?
Sure. I think a couple of points. I think the super specialist angle. I mean, I can tell a couple of personal anecdotes. So one was, of course, oncology specific hospital, right? I mean, the ideas can be pretty simple. So, I mean, this occurs in different stages, right? So, and of course, stage 1, stage 2 for certain cancers are completely curable. Yeah. So one of the simple ideas is, of course, as engineers, so this was a very simple idea, like stage 1, stage 2 cancers shouldn't be seen by like the very senior oncologist, because even they can be handled by very junior oncologists, and I think the protocols are very clear, right? But once you give this idea to very senior oncologists, he said, no, the patients want to meet me, right? So that's the idea. And of course, the doctors also want to give the patient experience. So in case, because I mean, see, how do you get your practice built up? It's like word of mouth. If the patient get treated better by the doctors, they're going to tell their friends and family that if you have this problem in future, I will strongly recommend that particular doctor, right? So that is one of the reasons where specialists and super specialists also want to, the cases which are, I mean, in an engineer's opinion, are very simple. They can be taken care through normal protocols, which are very standardized and all. So this is one. The other case is certain population. So for example, of course, I'm sure people exist in all of our friend circles. So let's say if a kid is having stomach pain and you go to Google and say, which doctor sees stomach pain? And the answer is gastrologist. So you basically call up the hospital, I want an appointment with a gastrologist. And of course, you go there and say, this is nothing. I mean, this is just indigestion. You give this kind of clemifene and it will get solved, right? So these are also things like people who have the resources, they are forcing the specialist and the super specialist to give time to them. And whereas, of course, you just have a limited number of the very senior person's time here, and that is getting utilized across all of the medical cases. And of course, I think this problem is more there in the metros and the tier towns where you have the population who can pay more. Yeah. I'll just take a pause here.
Yeah. No, thanks. I think, just to add to what you're saying, I have gone through some research with studies in the US, which have looked at adoption of technologies and which practices it helps, especially when they're on rotation, right? And so they go through different setups, and so they have these adoption stuff. And I think one of the findings is it definitely makes an impact in diseases or specialties where it is very clear what you should do. And one of the things that, to me, I'm not a doctor, again, and coming from engineering thing, once I found it, I was like, okay, that makes intuitive sense. One of the big things was, if you're a general physician, right, all this training and technologies don't help much because there it is, it is up to the doctor. And going back to what Dr. Ashwini was talking about, right? There are so many variables out there that it's very difficult for any program to come up with anything. So, where there is more certainty, programs seem to be okay. But when it comes down to, things where expertise of doctors there, that makes a difference. Now, I do want to, move on, and, there are quite a few questions from the audience as well. So one quote that I really liked was how, medical ethics are very different from business ethics, right? And, the stakeholders here are clearly the founders, the doctors who are the experts here. That's whom we're going to. And then, of course, the consumers who have the need. And I think there should be a lot of coordination between the three for us to come up with, either a technology-led solution or a healthcare-led solution. Now, given where we are, can we talk a little bit about, how to address some of these issues? And then we will open it up to the audience. So any thought on, how to address some of the challenges we see out here?
See, I personally think that the way to go forward is to make platforms where you all can, definitely for development of treatment strategies and device, etc. At least the doctor and the engineer should sit down together. And by engineer, I mean the
business,
technology,
the healthcare
manager who is developing things, right? Whether it is technology, IT enabled, etc., etc. Because you see, if you develop something in silos, then go test it, and then you find that no, this is not quite right, and this will fail, as so many models. So I think we should have some institution or some model, some platform where at least both these can interact very well, and then develop it, which is what I touched upon earlier.
Okay, thanks. Randeep? Go ahead, Jash.
Yeah, so 2 points. I think the very simple way to solve this, Madhu, is for founders entering the space is to have a very clear focus on patient outcomes, clinical outcomes first, right? Once you solve that, that's your product market fit. And then you think scale from there on, and you have to be patient to figure out that product market fit. The second thing, what Dr. Ashwini mentioned, in fact, we've been working on rolling out an initiative called Docs and Hackers to bring doctors and technologists on one platform. It's already something which is being run in the West Coast. And we were waiting for the physical world to open up because the Zoom world is limited in the doctors who would be willing to come to the platform. So completely agree. I think that's very much
I'll be eager to apply for the membership.
Me too.
Awesome. So we'll definitely, you will be the first ones we'll reach out to build this platform credibly. The other point I wanted to make, Madhu, which we've missed so far, and I think it's an important point, as we think about building scalable businesses from India in health tech, is to bear in mind that the price points of health in India are one of the lowest globally. Even compared to Malaysia, where like in a lot of other sectors, food and all, we are at par. In health, the medicine that we get for 1 rupee in India, we'll get for 11 rupees in Malaysia, right? So one of the things, not in all ideas, but in many of the ideas which will help, is to have a global view, to say, okay, once I build this in India, can I take this to a few other markets? Just like we've done that in the product, in the pharma space, leverage and India has one of the best healthcare talent. Indian doctors are one of the most experienced healthcare professionals, right? So I think that vision is very important. Otherwise, we'll keep struggling with subscale if we just focus on India as a market.
No, I think it's a great point on, in India to succeed, you need to know how to operate at scale in some ways, right? Because the price alone does not make a dent, and unless you're doing it in large numbers, it's going to be a very tough market to play in, especially with technology. Randeep, the last words are yours.
Yeah, I think, so I mean, we started with the panel topic, right? If you have to prioritize, I think if you need to succeed in India, your business model should be the priority number one, healthcare should be the priority number two, and technology is unfortunately the last priority, right? So of course, I think that's what I believe. I think if you have a product market fit and people are going to adopt it, yeah, and of course you can rapidly scale up. Yeah.
Thank you. So now I will take a few questions from the audience, and anybody in the panelists can take a shot at answering these questions. So this is from Swati. Standardization across is not possible, but we can work with the Gaussian curve. Basically, a majority of patients or investigations will behave predictably. Only a small number will be different. So why can't we start with the middle? And her point is, I think a large part of it can be the average or the standard. Not every case is different from the mean. So why don't we start having some kind of a filter, I guess, to treat and so take care of the system?
No, say her question demands a little clarification. And that is that what she says is the large majority, bell-shaped curve, the large majority would not fit in, because you see, it may be true for screening, but it is not for disease when the disease is completely different. And therefore the test which you order will be completely different from one to the other.
Okay. So
I would like to present another data point. So at least when I was working in a hospital and 40% of the revenue was coming from angioplasty and knee transplants. And when I looked at the data, that was exactly my question, Swati, that if 80% are fitting in that standard, then why aren't the packages including all the pharmacy and everything, right? Why are you leaving that ambiguity to the patient? So I would tend to agree that there are certain areas, and like I've been saying, right, you can't go from 10 to 100, and certain specialties will have much more variability. But there are many specialties which have now become very standard, like an angioplasty, a knee transplant, right? And at least pick up those areas where you can standardize, right? So yeah, just that data point there.
Okay.
I think just one point here. I think in non-clinical, there are avenues for standardization, and of course in clinical, you do have clinical guidelines or the protocols, right? But I mean, they seem to be standardized, but not all patients you can fit into these workflows. So I mean, this always remains, of course, somebody has written these guidelines, but they need to be updated every now and then. Yeah.
Thanks. So I have an interesting question from Gurpreet. So it's essentially talking about doctors, and given doctors play a very important role in this ecosystem, why is, we have been talking about patient experience, integrated patient journey and all. Why is there not enough focus on doctors, educating them, bringing up with new ways to help them as well? Because in general, they tend to be wary of technology, because that's how Dr. Ashwini started off, saying, I don't want to do this. Now, the other point, and this is probably true in many other sectors, I think it's less true in the healthcare system, is that doctors may fear that technology might replace them. How do you convince the doctors to adopt these new technologies?
So that will always remain a myth. I mean, I can jump in. I think Dr. Ashwini would be a better person to actually answer that. See, I mean, technology will always be an enabler or a helper or a support function to a doctor. They can optimize them, right? But finally, I think the patient will always take their independent decision. You recommend certain therapy, it's always with the patient, right? Okay. Do you want to have a surgery? I mean, the right to life is also with the patient. Even when they are like with the terminal disease, a patient can always say, no, I don't want any further treatment. I want to die peacefully. I mean, any doctor, any engineer must respect that. Yeah.
Okay. So the next question again from the audience is, if you can't have standardized healthcare, can we work towards integrated healthcare systems? I would think the answer is a yes. And I think most people now are, at least understanding that that is where we need to head to.
Absolutely. So see, the thing is that I'll give you a very small example and pause. Say, for example, we may have some Ayurvedic medication which decreases the need of large doses of expensive antibiotics, right? We can definitely integrate it. There is no doubt about that. Having said that, all these three are sciences. So we have to integrate them on the reason, bedrock of principles.
No, I think it's fair enough. So this one is a more technical question. It seems to, like, when you're thinking about data, right? The integrity of the data is often an issue, right? And a lot of it, of course, can be lost, mishandled, and altered. Now, especially given India's system, like we're just starting to adopt a lot of these things. We have so much more in legacies. How can this be tackled apart from HR training? Have you seen anything which is different from what would be the normal ways of saying, let me train people to start working on the systems?
So I would say one minor observation is technology with a better UI UX will help that large population, very busy with the clinical work, to adopt tech with lesser hassle, right? So I do think that is definitely one opportunity. And I think we've struggled till now because a lot of the healthcare management has gone with the cheaper version, not giving enough importance to the UI UX of the tech, right? So I do think that's an opportunity. And then if you build that for India, you can take it to a few other markets as well.
Yeah. Good. Okay, so this one is on AI. Will AI or can the AI help insurance companies negotiate better pricing with the healthcare service provider? In the process, the healthcare provider focuses more on quality, will have lesser profit. How can it be prevented? This is on data sharing issues. So I can share some insight. I know that, and definitely in the US, insurers use their data a lot to come up with, how they negotiate prices. But again, I don't think quality is necessarily an issue because there's enough work which shows that, quality or star hospitals tend to end up getting better deals with insurance providers because they realize if you're not part of the network, the insurer providers lose a lot more from not having these people on as opposed to having them in the network. So that's at least what we have found. But any comments from the panel on, data sharing and insurers getting the better of it?
See, well, I think in India, the insurance in last 10 years has improved in its penetrance, but it has not come of age. Every single day, we have to either fight with them or otherwise. And I've been sitting with some insurance companies' heads where we have said that, okay, you should get some new products out. Of course, the data, what data they have, they do not use the way it should be. They use it more to arm twist. Because I do know that the mandate of all the insurance companies, I dare say that across the world, is not to pay unless you fight.
Yeah, that's people have these jokes about car salesperson and insurance people, right? Randeep, any comments?
See, you have to understand their problem as well, right? So we don't have models by which they can give you optimal payment back. Yeah. And of course, if you look to the developed economies, they're both OPD insurance as well as IPD insurance. And OPD insurance is actually more popular. It gives you 3 times more revenue than IPD insurance, right? In India, the OPD insurance is non-existent, right? Because we don't have digital data in OPD in order to build models. So, and of course, if the data is not digital, how will you adjudicate, right? How will you settle those claims, right? Of course, settling the claims for IPD, it takes, I think, if the hospital can get the money back in 90 days, I think this is good start, right? Of course, I'm hearing some horror stories like within a year also you don't get the money back, I mean, they really want to make sure that this was not a fraud and this was done nicely. All the protocols were followed. The documentation was complete. And I think 70-80% of the cases, of course, we have also had discussions with a lot of these larger insurance players, because of course, with this UHI, I think all the stakeholders can come together. And I think the data pipe, which is common among them, if this data become interoperable, I think there's, of course, I started with that. There's going to be newer business models, newer companies which are going to come, and they're going to disrupt the way traditionally things happen, right? I mean, I don't have, right now, it's very difficult to say what will come in next 5 years, but I think you will see some exciting stuff happening on insurance as well. Yeah.
Thanks.
Yeah, and just to add, like, agree with Randeep, I think you will see some disruptive ideas, players coming in if the incumbents don't adopt tech and be more efficient and effective. And in fact, globally, if you see in the last 5 years, the top 10 funded health tech companies, 4-5 of them are in the insure tech space, right? And we think India is ripe for it, just given the NDHM foundation being laid out. There are regulatory hurdles, and hence you're not seeing startups right away in the insurance space. But there are different ways the startups are approaching, right? They're starting with one part of the patient journey, but I'm sure regulations will evolve, just like we are seeing in the e-pharmacy space. There were restrictions earlier and now opened up. And that's the current posture of the Indian government and the health ministry as well. So yeah, I think the future here is some disruptive founders' ideas.
We can actually have a single theme conference on this. I'm not talking of session, single theme conference on this.
Yeah, I think that we'll have to defer to, Soumya and Sarang on that. Now, I'll just take two questions. Just two more questions in the interest of time, right? So the one is how, given that most patients feel that even doctors, human doctors, lack emotion, how do you think startups in the health tech and the telemed space can tackle this worsening issues?
I think it is going to worsen it further. Telemedicine, you see, the premise which I started by this thing is that communication has to be full of a feeling that you are close to the patient. You know his problem, you empathize. I've been taking a lot of lectures on medical negligence, and it says that, okay, if you empathize the patient, a lot of suits just fall through. So communication has to be that. Now, in telemedicine, again, if you're not face-to-face, agreed, there will be video, but you still cannot have that kind of a thing as you have in person. So I don't know whether we really can help on that.
I think I like the use of the word empathy, right? And it's all about delivering empathy and understanding the consumer, the patient here. So if we can get to that stage, maybe we can tackle it. But again, I'm cognizant of the problems there. Let me, end this session with just this last question, right? So we are going to see more doctors coming in, right? So the government sees the need for having more doctors. We're seeing an increase in MBBS, BD seats and all that. Now, given that, how do you think the profession is going to be different? For young doctors, are they going to see a different world than what you saw, Dr. Pillai? So any comments on that? And we will, stop with that.
You want me to do that?
Yes, you can start, and then Jayashree and Randeep, if they have anything to
The
add.
experience tells us that doctors are not doing that well as far as clinical astuteness is concerned, because they are depending more and more and more on technology-driven investigations, processes, and procedures. So they've kind of, the clinical medicine has taken a backseat, which has affected the outcome because of many things, which has affected the outcome. In the interest of time, I'll keep quiet now and let others.
Jayashree.
I think it's a fair challenge. Also because the core medical education being regulated, there is limited space to kind of bring that fresh thinking. So I mean, while that remains a challenge, I think some areas or some initiatives which are helping, even the PGP Max healthcare program, for example, right, is a great platform for healthcare professionals to understand what's emerging and to at least immerse in that and think in that direction. Dr. Ashwini's concern is a very valid concern. I think just blind westernization, I think, is negative. I personally feel we shouldn't try to learn from the US healthcare. It's one of the worst. They spend 70% of their GDP on healthcare. And if we do dollar to dollar, if India is X, US healthcare size is 100X, right? And I don't think that's something to learn from. I think we should just learn from their mistakes and not do those mistakes. So yeah, I think I don't have an answer to the question. I think it's a fair challenge on how are the new doctors not blindly adopting westernization and just diagnostics, right? Like,
yeah. Thanks, Jayashree, and thanks everyone, even including the audience, for staying on. And hopefully you had a very insightful discussion. Thanks to the great panelists we have. Over to you, Nipun.
Right. Thank you, panelists. This was really enlightening, hearing all insights from different aspects of the same ecosystem. I'll introduce Ms. Smitha for the next panel. She is from the current AMPH batch and Managing Director of Indo-British Hospital in Vijayawada. Over to you, Smitha.
Thank you, Nipun. Welcome, good evening all. Welcome to the second panel discussion of the day. It's themed New Age Models in Population Health. Just to give you a brief overview of the session's focus itself, we're increasingly seeing the experimental use of technology and analytics in designing new healthcare delivery models to improve access and quality of health in resource-constrained settings in order to reach large populations. So in this panel, the speakers will be discussing some innovative new models they have either been working on in their organizations or the ones that they have come across as very inspiring and those that could achieve the goal of making healthcare available to masses. So with much pleasure, I introduce the panelists for this session. The first speaker we have is Jagdeep Gambhir. He's the founder and chief executive officer of Karma Primary Healthcare. Jagdeep Gambhir, he is with the vision of solving the healthcare accessibility problem in rural India. Jagdeep found his tech-enabled healthcare startup, Karma Primary Healthcare, in 2014, which now operates over 25 rural telemedicine clinics and multiple public health partnership projects. Even though Jagdeep started off as a technology analyst, his deep inclination towards healthcare made him work with organizations like Population Foundation of India and Innovators in Health, where he has started and worked on tuberculosis treatment program in rural Bihar. We're looking forward to learning from his experience. And also, I can't help but say with pride that Jagdeep is an alumnus of Indian School of Business, Hyderabad. Welcome, Jagdeep. The second speaker we have today is Dr. Bhavna Sharma. She's a consultant and country lead at Resolve to Save Lives. Dr. Bhavna has extensive experience of working in drug research and development across South Asia. She established DNDi India, completed 3 regulatory clinical studies, supporting 2 new drug registrations and new treatments. She has been instrumental in the implementation of pilot project for policy change in the national program as well. She has worked on multiple collaborative projects with the government, private and not-for-profit organizations, in the areas of clinical research, life sciences, and infectious diseases. Given her extensive experience, I'm sure we can gain insights into how healthcare models have evolved over time to reach larger populations. Welcome, Dr. Bhavna. And third speaker we have today on the panel is Rishabh Chopra. He leads strategy and partnerships development, South Asia at PATH. He supports creation, development, and implementation of interventions that accelerate public health innovations by collaborating with other NGOs, government, and private sector partners. Rishabh works at the intersection of philanthropy and public health impact, forging partnerships with Bill and Melinda Gates Foundation, United States Agency for International Development, Center for Disease Control and Prevention, the Fleming Fund, and the Rockefeller Foundation. He too is an alumnus of ISB, and we're looking forward to hearing from you, Rishabh. Welcome. Moderating this session today would be Professor Raghuram Bommaraju. He is the Assistant Professor of Marketing at the Indian School of Business, and his main area of research is Salesforce management. Professor Raghuram, welcome, and over to you to lead the discussion. Thank you.
Hey, thank you, Smita. So good evening, everyone. So thank you for joining the session. So Gautam couldn't join the session. He has some personal constraints because of which he couldn't join today's session. But I'm hoping the rest three of us can still enlighten you with our discussion. So as Smita mentioned, so my main area of research in Salesforce management, but I'm slowly starting to get an interest in the healthcare space, and I'm working on a couple of projects in the TV space. That is how I got roped into as a panelist for the session. So we have discussed and we thought maybe it will be a good idea for each of the speakers maybe take 5 minutes and explain their current business model or the current healthcare delivery model. I guess for Jagdeep, it will be mainly talking about the Karma Healthcare, but for Rishabh and Bhavna, I request maybe you can take one of your recent or maybe more successful healthcare delivery model and maybe spend 5 minutes so that I guess all the audience will be on the same page. So I request Jagdeep to take over.
Hi, thank you so much, everyone, and thanks MIHM for having me. My name is Jagdeep, and I'm I'll probably spend the next 5 to 10 minutes to explain a little bit about our work. I know the previous panel itself was on technology-led healthcare models, so there has been a lot of learning around that. So I'll probably share what we do and also why we do what we do at Karma, a little bit about our operating model, and share some insights and learnings that we have had based on our learnings over the last 5 to 6 years. So our mission is to enable access largely to a rural and semi-urban audience, right? And I think when all of us talk about healthcare delivery models, our focus has been that how do you enable the access gap in the rural and semi-urban areas, right? All of us know that there is a significant doctor shortage, and general access to care in rural and semi-urban India is a problem. While there is a lot of work that is done on the public health systems, there is data to suggest that people still seek care from the private provider, and in many cases, either the private provider is either in an urban setting or is an informal provider in a rural area. It leads to various problems related to healthcare, whether it is antibiotic abuse or kind of lack of transparency in the healthcare system. So we at Karma kind of follow what is a nurse-assisted telemedicine model, right? In which the idea is that how do you actually bring in care to the community, right? And this is for us largely done through an assisted care model. There was a previous in the previous panel as well. There was a lot of discussion about telemedicine and the lack of connect with the patient and all, right? So our focus is to kind of enable a nurse-assisted model wherein we operate what is called an e-doctor clinic in a rural area. It is, it is a clinic where a nurse will facilitate, digital consultation between a patient and a doctor, right? And there could be, there are specialists as well as general physicians who are available. And then the clinic is a one-stop solution. You can get diagnostics, pharmacy, and the nursing services there itself. We currently operate about 25 such clinics in 4 states in the country, as well as now are looking to scale to about 80 clinics in the next 2 years, right onto that. So I think the key model, the key focus of our model, as I mentioned, is the nurse assisted care, and the nurse, having a nurse actually makes sure that the dialect differences, we are talking about rural, right? So there is not only one language, the dialect differences can be taken care of by the nurse. The nurse can actually gather more clinical information about the patient, right? Which is otherwise not possible in a mobile only consultation play. And in a post-COVID world, as I think in the post-COVID world, our model is also migrating to a phygital kind of a model wherein we have the physical clinics and they'll continue to operate, but we also are kind of looking at a more comprehensive end-to-end delivery where especially some of the messaging and the chronic management part of the spectrum could be done by a mobile app, or the patient doesn't need to kind of travel to the clinic itself. So, let me quickly share a few learnings, right, of what we have learned, right? So I think the first key learning, is the assisted care model, right? And I think, while, non-assisted is probably easier to scale, having a, human-centric physical delivery, which is assisted by a paramedic nurse is critical and core to our mission. We have seen now have enough data to compare COVID versus post-COVID scenarios, and all the patients that we were consulting online, right, through a non-assisted model. As soon as the unlock happened, most of the patients actually went back to the clinic itself for the consultation. So I think there is I think evidence to say that for a curative service delivery part, at least the nurse-assisted model, I think is core. The second learning, I think, and when we talk about rural, right, and this is about providing care in a resource-limited setting, right, having a more comprehensive solution is required. We cannot have a TB only solution, right? Because a patient is not going to come into a clinic to say, okay, please, treat me for a particular ailment. The more broad-based and the more kind of, comprehensive the offering is, right, whether it is in terms of, specialities or diagnostics and everything else, I think is core. And that is something that we are kind of, actively working on, right, to kind of have a single stop solution, right, for the patients that we have in rural India. The third learning is, I think, and this is something, is coming because of MIHM, is that, in a telemedicine, kind of setup, we would refer a lot of patients, right? And, currently our ability to actually have a look into, where is the patient going, if at all the patient is going, and what is happening to the patient and reverse is really not there. So vertically integrating, our service delivery, and again, with NDHM, it is, hopefully going to be a reality soon, is, I think, going to be very interesting. And, the previous panel as well, a lot of people talked about integrated care. And I think, it is, the amount of impact it could have on rural, healthcare, is phenomenal. And I think, that probably also will make viability of, nurse-assisted telemedicine models, or actually any primary care model for that example, interesting to see. And the fourth point is that, I think when we talk about, population, health management and technology models, I think, we tend to kind of ignore the, the HR aspects, right? And I think, empathy or compassion with the patient, right? I think sometimes, we have actually realized in our work that, ultimately it's not the software, or, not the AI engine on the back end, right? Which actually leads to an impact or why a patient is coming. It's about, delivery and, making sure that, there is compassion in the delivery that we kind of look at. And, I think it's always a good time for all of us to reflect, to say that technology can only be an enabler. It can't be the end solution for most of the healthcare deliveries that we do. So I'll probably stop here and, happy to, discuss, and have, handle any Q&A as we go. Thanks.
No, thank you, Jagdeep. I think very insightful. So may I request Dr. Bhavna next.
Thank you so much for the opportunity to talk to a panel which is health enabler. So I would like to start off first with that. What is the burden of disease in India? And because of the change of the disease pattern in India, we are changing and wanting to have health enablers. We were basically a communicable diseases. That means infectious disease country, where we were giving treatment and getting the patient was treated and went back home. So with economic development, and if you see it state-wise, you will see the difference in burden of disease. So the requirements for each state differs again. So if you look at the model, the cardiovascular mortality or the complications due to non-communicable diseases, due to the economic development, we are seeing it more. So now we are a dual burden disease country with a lot of communicable diseases and a lot of non-communicable diseases. So we have to look at models from that perspective on what is the shift you see now? The shift is that we were previously giving treatment and not following the patient. What exactly Jagdeep has said is that we did not have to actually follow the patient for a very long time. But now with non-communicable diseases, we'll have to change our modeling patterns, and we'll have to think of our healthcare in a broader perspective, because we'll have to provide care long-term, lifelong. The patient has to take medicines and be taken care of lifelong. So we'll have to look at models from that perspective. Just to give you a perspective, we were looking at this kind of a change, and I have worked extensively in communicable diseases. So the modeling in that kind of diseases is different from a patient care perspective. Now we looked at India and we thought how we can look at models to deliver a care lifelong. So we took a disease which had all the tools available. That means hypertension. At the moment, 20 crore of population in India is suffering from hypertension. And there is an unmet need, not only in public sector, but in private sector. Approximately 30% population goes to public sector and 70% goes to private sector. So we have to look at both aspects when we are thinking of enablers for healthcare. So we took up a low-hanging fruit in our pharmaceutical world, we call it that way. That means it's got all the tools available. That means it's got drugs, it got diagnostics, it's got all the preventive care modeling. So we could actually take that up, and we started modeling around it and developing systems to be able to deliver a good treatment care model for the patient. Because whenever you look at healthcare, you look at the patient's perspective. We are looking at a population of 20 crores. So first we needed to know the exact potential and database we are looking at. And that's how we started off. So we started off with the 30%. That means we started off modeling in the public sector first, because it was easier. India has a parallel system of public sector delivery for hypertension through primary healthcare center, health and wellness center. So what was the lacuna in that gap analysis? We developed, it's a WHO HEARTS package, which we actually implemented. What is the implementation of a package? In that, you have various aspects. We had developed a single protocol, that means easy to follow by the doctors, nurses, ANMs in the at the primary care level, at the doorstep. That means it last delivery mile. It's easy to continue the care at the for the patients. And then what we needed, what feedback would we need for this? Then we developed all the system. We would need drugs at all the facilities for the patient to pick it up. So we needed tools to forecast drugs at the public care center level. We would need tools to model that around, which means that this is not a treatment where the patient comes, takes the drug for 10 days and goes back and it's treated. He needs lifelong care. So you needed a modeling around those tools to be able to actually calculate how much drugs have to be procured, what budget needs to be implemented in a country like India. So if you look at, we have done all these modelings and we have tools available now for the government of India. We developed the India hypertension care initiative with India and Government of India, ICMR, WHO, and we have developed simple protocols for across the country. That means all the states in India have a protocol based. Then we developed an information system, which is a technology, which we have developed a tool called Simple, whereby you can actually get the patient care data and you can actually follow the patient, because in this kind of long-term diseases, you need follow-up, you need how much drugs you require, what is the outcome coming on? Because if you realize, non-communicable diseases lead to a lot of deaths. That means the cardiovascular mortality in India is right now 15 to 20 lakhs per year are due to cardiovascular mortality, not only because of old age, but younger population is being affected. The economically viable population is also affected. That's why we took up hypertension as a model, and we have been delivering it. And the tool, the modeling around it is we developed a tool to be able to monitor the patient. Now, how do we take patient care to that? This is for public sector. In that, we have SMSs for the patient to come back and pick up their drugs. You have call center calling them. You have preventive material available for them to change their lifestyle, behavior, to be able to manage this disease themselves. And there are, for now, we come to, this is for the 30% of the population, we looked at the modeling. Then for the 70% of the population, which goes to private sector, we require a different mindset. First, we want to know what is the unmet need. We had an unmet need, and we realized there is almost 40% to 50% population which is not being able to, is not taking medicines, because it's a reverse modeling we did through the sales figures in the market. What is the, what are the drugs being sold? How many patients would be taking it across the year, and how many patients are being treated in India? And that's the, I could share all the papers with you. And then that modeling gave us a very high unmet need of hypertensive patients. Then we looked at various models on private care, because private care is very fragmented and they only look at patients once and they don't do a follow-up of the patient. So we need to change the mindset of private sector. We did a very big study around it, and we realized there is a lot of loss to follow-up in private sector. So we need some kind of tools for them to continue, for continuum of care of these patients. We would require to develop some tools for these primary care centers. And we will also have to get some kind of an education. We have tried with doctors, we are trying a pharmacy-based model in which we are saying that the pharmacist actually, when they come for their refill, he takes their blood pressure and refills their drug. For a hypertensive patient, if the blood pressure is raised, then they need to be escalated to the next level of medication. And that could be actually technology-based kind of a pop-up coming up to the doctor, and the physician could actually increase the medication. So we have looked at these modelings. We have not yet been able to showcase which would be successful, because each state, each region in India is different. So we would require different kinds of models to be tried. We are also trying an insurance-based model for people who are going to take up insurances. As India is going towards insurance-based model, we don't want that we lose out on, the patients lose out on that. And the selling point for insurance company is, because the in-hospital care would be less if you give the primary care to the patients. And we are trying to model around that. It's open for discussions, and it's really a very difficult thing to do, and get the insurance company to be motivated for this. So this is how we are looking at the whole landscape of non-communicable diseases. Thank you. Over to you.
Thank you, Dr. Bhavna. Rishabh?
Thanks. I hope you're able to hear me well.
Yes.
I think both Jagdeep and Dr. Bhavna has set the stage of the multiple things that I had in mind. But I think the most important thing to realize is any model, whether it's new age or old age, will succeed, especially from a public health perspective, only if we keep the health outcomes, health impact, and fact of focusing on saving lives as the most important goal. And I think to do this, there are twofold objectives. One is to strengthen the public health facilities to help drive scale and efficiency in their operations by strengthening their systems and the training, and also by engaging the private providers, where, as Dr. Bhavna mentioned, about 70% of patients seek care. That without that engagement and bridging the gap between the private and public sector, it would be a difficult one. So, and the other point, I think the previous panel also talked about this, both Professor Madhu and Jayashree, is defining patient journeys and talking about patient empathy and hearing patient voices. So for any public health program to succeed, you need to have the voice of the end user, which is the patient, to be able to inform the program. And I think the model that I have chosen to talk about is something that PATH has actively worked on over the last 8 to 10 years, is in tuberculosis. And the problem statement, of course, for a disease like tuberculosis is for an infectious disease like TB, it is very important for you to know the full extent of the disease and the true burden of it. And most importantly, you have to engage with the private healthcare providers which are treating most of your patients or diagnosing them. So the model itself was called earlier as PPIA, which is Private Provider Interface Agency, and later it was termed as PPSA, which is Patient Provider Support Agency. Essentially, it's a bridge between the public and private sector. with the aim of that an external agency takes up the job of reaching out to the private sector providers and engaging them in the program in such a way that their incentives to retain the patients are also taken care of. So that was the problem statement that we began with, how to reach out to this large section of patients. And setting up this intermediate agency, we started the work. And I think the few principles that we kept in mind is the patient choice, right? The fact that 70% of patients are going in the private sector, or being in the private sector, we should respect that choice and engage with the private providers so that you can increase the quality of care, of course, both diagnosis and treatment. The other important piece that we realize is important is engaging all kinds of providers, right? Both modern medicine as well as Indian medicine doctors. And you could choose to figure out what role do they play in the whole continuum of care of the treatment. The interesting bit that we also looked at is the use of technology, and I'll pick up on the discussions in later on as well. But there were elements of having a patient and provider registration system called NICShare, which was the bedrock of all the information that was flowing around. Of course, also applying new technologies because tuberculosis treatment, 6 to 8 months it takes to care to finish the treatment. It's very important for the patient to continue on treatment and for the system to know that a particular patient has taken all the drugs. And we began the pilots in 2014. In fact, it was tried in Mumbai, Patna, and Mehsana. And we began by sort of mapping the private providers, which is a big issue. Of course, with the NDHM coming in, there might be more provider registries, but it was very difficult for us to identify, even in Mumbai, how many private providers are actually there. And it was a 3-month mapping exercise where we mapped about 12,000 facilities, healthcare facilities, small hospitals included, about 3,500 private practitioners, and about 1,200 pharmacies all across Mumbai. And then we sort of also did interviews with providers, identified that aggregators of care, it's better to engage with them rather than engaging with all the providers so that you focus your limited resources. And in 3 years in Mumbai, we were able to identify 65,000 new TB cases in the private sector. And of course, we worked with 2 grassroots NGOs called Maharashtra Jan Vikas Kendra and Alert India. That was very interesting, and also had a model of medical representatives that's prevalent in the pharma sector to be able to go out and talk to these doctors and convince them to be part of the TB program. Initially, it was a donor-funded program that later was transitioned to the government. And in today's world, the government is actually paying for setting up these PPSA agencies to be able to engage with the government. And I think if I share the numbers, right now there are about 700,000 health facilities and private providers registered on the system. There are about 1,800 NGOs collaborating across the country. And in 2020, of course, notwithstanding COVID, about 5.5 lakhs TB patients were notified from the private sector. And the total case notification was about 18 lakhs. So the engagement of these providers with the model what started in few cities is now put across the country, and there are principles of the success that we were able to see by working closely with the government. So those were a few points that I had to share. Back to you, Professor Raghu.
Yeah, thanks, Rishabh. So it's actually we have like 3 good different perspectives here. So on the one hand, we are Dr. Bhavna, who talked about like non-communicable diseases, like more like chronic diseases like hypertension. How do we manage that? Whose burden is very high, right? So maybe the treatment and diagnosis may be simpler than compared to, let's say, a TB diagnosis and treatment, but the burden when you look at the overall population is pretty high, and the Rishabh is working on probably how do we maybe eradicate this TB. The first step is diagnosing those cases and giving them proper treatment. And the third, we looked at from Jagdeep, who is trying to provide end-to-end services, right, for all the care, all the kind of diseases that people might be encountering at the primary care level. So let me start with maybe Dr. Bhavna asking, so hypertension seems to be like easy to diagnose, right? At least pardon my ignorance, but it seems like an easy thing to diagnose and maybe to treat. But you did mention that there's a huge difference between number of people who should be actually taking these medicines actively versus who are actually taking. So where is this bottleneck? So is it coming from, is it the economic reasons that are preventing people to be actively taking these hypertension medicines, or there's some other issues which is preventing people to actively manage the hypertension?
Yeah, it's very interesting. If you think of it, it's a patient's perspective. Hypertension doesn't have any symptoms. Technically, you might get a slight headache. You might feel a slight headache. And as Indians and general population, if you think, people think if you have some symptoms, then only you have to go to a doctor. If you don't have any symptoms, you don't have to take the medication. That's the usual scenario if you think about it. But with hypertension, what happens is your body resets your button and you are comfortable with a slightly higher blood pressure. And you might not have any symptoms. But when you take the medicine, it comes down and you feel very happy and relaxed. That's why you will not take the medicine. If you see the case of tuberculosis, we have a very good treatment, but people don't take the treatment for 9 months because they feel well after 6 weeks. After that, they stop taking medication. And that's why we develop drug-resistant tuberculosis and other complicated tuberculosis. And that's why we have not been able to actually manage it. That is one of the reasons why tuberculosis is on the rise and we have not been able to manage it well. So for a disease which does not have symptoms, it is actually through, you will have to educate people and then only they will take the medicine. If you think about it, how will you educate people? And the problem with hypertension is you will end up in a heart attack, you could end up in a stroke, you could have renal failure associated with high blood pressure. But that will only come and you will not even realize it when you are a victim. And if you have any of these complications, you have a lot of palliative care requirement. You will require a lot of care after that. So that is a big burden on any family. So what hypertension needs and specific hypertension and diabetes require is basically preventive care, education that everybody needs to take medication. If you don't take medication, you will end up with a complication. And for that, as you know, with tobacco, if you've seen tobacco campaigns have been successful by smoking has reduced by campaigns which showed the consequences of smoking. Similarly, we are also trying to educate people through the consequences of uncontrolled hypertension. But that's the basic reason why people do not come back to physicians for follow-up.
Okay. But you did mention that you tried this sending SMSs to patients and so on. So what are the initial results that you found from sending those reminders to patients?
In fact, we did it with PATH. We did a project with PATH for private sector. And we took these Ayush doctors, that means all these Ayurvedics and all other doctors, and we did it with MDs also. And we actually had a call center, which was actually quite successful in getting the patient back in the folds of follow-up, because they realized that. And we tried actually a number of models in that. We gave drug vouchers, that means drugs were available for them. And we also associated the complications with hypertension if they had in their family and others. So a social worker was actually educating the patient. So we did see a higher turn up of patients and follow-up when you actually send those SMS and send those call centers. We tried it in private sector with PATH. We are trying the same model in public sector. And we are seeing that there is because with the technology-based modeling, as you know, we have simple in which we can actually send a SMS if the patient doesn't come back after a month. If the public health facility, health and wellness center, is giving the patient a 1 month treatment, exactly 4 days before, the SMS will go from the technology-based simple to the patient that you need to get your drugs. And it has been seen not in India, but worldwide, that these kind of applications help people to be more attention to their diseases and their health. So we tried all these, and we are still in the process of trying newer models.
Okay, thank you. So Jagdeep, the next question is for you that I have. So what kind of technologies that you're leveraging, like to deliver maybe health in the rural and semi-urban areas, right? So I understand one is the video calling, but I'm sure there's much more that is going on in the background. So maybe if you can give us some more details on that.
Yeah, sure. So I think, great question. I think, when people think about technology, one only tends to think about, having a video call. I mean, that one can do on a WhatsApp as well. But I think the role and power of technology, right, is actually much more than just a telecall, right? And let me explain, 2-3 things, right? And one of the things is Dr. Bhavna said, right? And I think what Rishabh said, you can use technology to actually monitor patient over time, right? Whether it is 6 months or whether it is a lifelong thing, that obviously is very powerful in a non-tech system, that is very difficult, to do that. The second thing is that you can improve care provisioning, right? So, on a telemedicine platform that we operate, we not only provide general physicians, there are 5 kinds of specialists which are available. As we go along in time, more and more specialties and access, could be, provided to those patients. There are a lot of IoT devices now which are available, handheld ECGs, digital stethoscopes, right? Those are technologies which are used again to kind of improve, care provisioning, as I mentioned. There is a huge role of AI, right, and clinical decision support systems, right? As we look at this, can you actually improve, the quality of care, as well as can you improve the, reduce the errors in diagnosis, right, through technology, through AI. Again, there are, it has been talked about, and there are significant use cases of that. And operational efficiency, right? In our current model, a nurse on a daily basis cannot see more than 10 patients, right? Because, she has to kind of do a lot of patient workup. But, can you improve your technology systems? Can you improve your software systems, supply chain systems, right? Thereby increasing the throughput, of the system as well, right? So can you improve from 10 patients a day to 12 patients a day, right? That will have massive impacts on the PNL as well, right? And that again will make, many of the, the models more viable. And, having more integrated care, right? That, I think with tech, you can remove the barriers of primary, secondary, tertiary, right? I think a patient could seamlessly move from a handheld mobile app to a teleconsult facility to a tertiary care hospital, right? I think, having that data, in an integrated manner will again improve, patient health outcomes, right? So these are some of the things that we kind of, use in varying capacities, in our system. And I think that's where, we think it will go.
So Jagdeep, you mentioned about the clinical decision support system. So are these available to the nurses at hand, or these are generally given to the doctor? So what is the role of those systems? Can you maybe elaborate a little bit more?
Yeah, so both, right? Actually, it depends, right? So one of the key roles of, again, because it is telemedicine and it is again dependent on the data that the nurse is generating, and the nurse is not a doctor. You can do a lot of training, but a lot of triaging can be done, right? A lot of screening can be done by some of these, clinical decision support systems. Looking at the past history of the data, can you screen for cancer early, right? Or can you actually continuously screen for early, because cancer will probably not show much symptoms, right? As we look at that, right? So there is a lot of use case on that. And then on treatment as well, there are standard treatment guidelines. Again, we are in primary care, so some of the treatments that we do is fairly straightforward, right? So we are not really doing there are standard treatment guidelines. So ensuring that there is the standards are followed, right, and there is not too much variation between one doctor to other. That is again a use case that it does. Many doctors don't like it, tweak it at times, but I think we still try to push it as much as possible, right? And I think that's the role of CTSS that we use.
Okay, thank you. So Rishabh, so coming back to the tuberculosis thing, right? So when you said that private providers are getting engaged, right? Since most of the patients, I think, whether it is for TB or for even for other diseases, are still rely on private providers for whatever reasons. But do you, like, is there a reluctance from the private providers to engage with the TB patients, or maybe give out these notifications which have a longer term implications for public policy or what the government can do, right? So how are you able to overcome that resistance from the private provider side?
Absolutely, that's a great question. And I think when we started the work back then, when we spoke to multiple private providers, why are you not engaging in the government program? At that time, the government felt that if you are a private provider, you notify the case and refer the case to public systems, because they were more confident of treatment in public systems. The private provider is saying, hey, I have done my medical degree from the best institutions. I know tuberculosis and I'm treating so many patients. Why should I refer my patients? So I think the patient retention piece was very important. And I think that was a major shift that happened. And the other point was about the difference in regimens, where back then in public system, there was one set of regimen. And in the private sector, they were using the fixed dose combinations that was prevalent. So that's the other thing that, one is the economics, the patient retention, as well as the different treatment regimen that dissuaded many private providers from engaging. Of course, things have changed over the last few years, with government making a lot of changes, and also through our model, we said, let the patient remain with you, but we have to be sure as public health system that you are doing quality screening, diagnosis, and treatment, and we will help support your patients to continue the treatment through either use of technology or having the healthcare workers remind the patients. What that started doing was there were repeat consultations back to the doctor, because the patients were continuing for a longer period of time in the private sector. So once they started getting that business point clear, they shed their inhibitions and they started notifying the case. And I think in cases of drug-resistant TB, I mean, it's a very expensive course of treatment for people who can't afford it. Their government had set up referral programs from private to public, where there are drug-resistant treatment centers across many cities now. I think about 250 across the country. That help the MDs and chest physicians refer those cases, those who can't afford public sector. And I think that these are some of the changes that happened. But I think the other big change that is happening now beyond TB also is, as some of the other speakers talked about, the NDHM, which is now known as Ayushman Bharat Digital Mission, where there is a creation of health IDs called ABHA ID. There is a health practitioner registry, health registration for the facility, and also an ecosystem for ensuring that private companies can come in and integrate the systems with NDHM, like Jagdeep also mentioned. And there is focus on interoperability of data, not just from private to public, but also within the public and different programs, the vertical programs that we have. Of course, it's a long shot and a lot of work needs to be done, but the beginning has been made. And I think eSanjeevani is a good example of how the doctor consultations about more than 2 crore eSanjeevani consultations have happened. And I think more and more private providers will be keen to be part of that system. But I think for TB, those are the things that change really the approach of providers.
Okay. Thank you, Rishabh. So Jagdeep, this question is for you. So how do you, I'm guessing, recruiting doctors for e-healthcare model, right? So it may not be that easy. So what kind of challenges you're facing and how are you overcoming those?
Yeah, I think yes, it is. It is a challenge. I think again, let me first explain what are some of the 3-4 key pushbacks that we get. Right. First is that many doctors are not tech savvy. Right. So it's like we don't know what is this software and all. We would rather use a pen and a prescription and kind of do work, and that's what we have been doing. So just general tech knowledge, especially for some of the older and more senior doctors, is not available. They're not comfortable kind of changing that, right? So that is one. B, I think many doctors, and maybe rightly so as well, are not very comfortable in a teleconsult way, right? I mean, they would more rely on, and very rightly so as well in many cases, on more physical touch, right? In that sense that they need a physical examination of sorts. So that's the other thing. The third is that I think the career pathways, right, for many doctors, right, would not include only focusing on a teleconsult. So that I think is another key thing, right, that many of them would want to, especially on the surgery branches, right, would want to kind of work in large hospitals, right, kind of do a lot of procedures and operations, and you can't really do a procedure on teleconsult, right? So that is things. And the fourth is a financial incentive, right, that I the OPD payouts that we could potentially provide might be not very lucrative for some of the doctors. So these are kind of the 4 or 5 challenges that we face. The way we have solved it is that I think we've become smarter on targeting which kinds of doctors would kind of be more relevant and suited for our model, right? So kind of looked at age profiles, which geographies, what kind of work they're doing, and kind of have looked at that, right? So we do employ a lot of doctors who are kind of keen to work from home, right? So one of the benefits of a teleconsult is that you can work from home. You don't need to travel anywhere.
Right.
There is less chances of violence as well, I think, in this teleconsult. Sometimes, that's also unfortunate reality, right? So we have become smarter that before evaluating or, when we have to recruit a set of doctors, we are now, we would actually do our own backend analysis that, will this person join or not, right? And then on the economic side, our provider payment mechanism is fairly different. So we actually do not employ full-time doctors, right?
Okay.
Actually leveraging the excess doctor capacity on the private side, especially in the models, right? So if I'm a doctor in Mumbai, I might be seeing most of my patients, between, let's say, 5 p.m. to 7 p.m. because, that's
right.
But I might have, more capacity, right? And I might be sitting in my clinic, right? And I have more capacity. I'm comparatively free between, let's say, 11 p.m. to 3 p.m., right? So we actually do a counter, reverse and talk to the doctors. They give us a fixed time. That actually works very well. So, with that, we are able to get doctors at a, comparatively lower, price point versus hiring them on a full-time basis. So these are some of the strategies that.
No, I think that is very insightful. I think maybe looking at the profile of the doctors and especially the part-time thing is probably, I think, would have worked for you very well. I think recruiting full-time, as you mentioned, maybe prohibitive both from a cost perspective and also from their career progress perspective. So yeah, I think that is very insightful. Thank you, Jagdeep. So Dr. Bhavna, so you mentioned that for the hypertension, since in India patients, I guess most of patients, even for, I guess, many diseases, may be relying more on the pharmacist, right? So not necessarily even consulting a doctor. So you mentioned that you are looking into how pharmacists can help in actually maybe either increasing the dosage, maybe decreasing the dosage. So can you elaborate on a little bit more? Like how is that going to work? So will they need an approval from a medical provider, or they are kind of authorized to take maybe minor improvements or minor changes in the medicine?
No, they are not allowed to do any changes in the medication. Pharmacists are allowed to only dispense, but the advantage is for a follow-up. That means whether your hypertension is controlled or not, and for the continuum of care. That means the patient doesn't have to go back and to the doctor, pay the fees. So that means your out-of-pocket expenditure reduces. So you just measure the blood pressure. If it is within control, then you get the medicines dispensed, and you can continue with the same medication till your blood pressure is controlled. So that's the way we are looking at it from that perspective. If your blood pressure is uncontrolled, then the pharmacist is attached to the doctor, and he sends the patient to the doctor, where he will actually change his medication or upgrade his medication. That is only allowed to be done at the doctor's level. But for continuum of care and reducing the out-of-pocket expenditure in private sector, this is one of the models which we have been thinking of and trying also. In fact, we have tried with ISB only. So we are still working on that and working through those various modeling. One thing I would like to really add to this, because we are looking at technology. I think when you're looking at leveraging technologies and models for a country like India, we should look at the population-based VR. And we should think of out of box. We cannot have one single model working for any of our country or a state, even districts could have their modeling. So we have to think out of box when we are thinking of India. Whereas when we say that everything is going to be linked to the public sector, let me tell you, if you have looked at various countries' models and looked at healthcare models, their population base is very less. Even then, the data systems have collapsed. So every country has to change according to the systems, the burden of disease. And we are looking at a very large population base. So we really need to think of out of box when we think of non-communicable diseases. Whereas when we talk of communicable diseases, we are looking at elimination. We are looking at notifiable disease. And we are saying that if we are able to treat it, then it will not happen in India. Like we've been able to eliminate leprosy, we have been eliminate smallpox, yaws, to various multi-pronged effect. So now we're looking at a disease which will not be eliminated. So we really need to think out of box and think of multi healthcare systems whereby we can cater to a large population. So this would be my thought process when you're looking at models for healthcare. And if you look at different models, both the models can work simultaneously. Public health sector, economic strata of the patients will determine which healthcare system they will go to. So I think that's how you should look at leveraging technology.
No, I think that is very insightful, Dr. Bhavna. I think given the heterogeneity in our country, right? So whether in terms of economic heterogeneity or the number of languages we speak or just the way we approach doctors, I'm sure it's very different in different parts of the country, and even within a state, it could be very different. So I guess for any model to be successful, we need to customize it to the local, I guess, the customs and practices. So yeah, thank you for that. So Rishabh, I'm just curious, like, I'm sure the COVID must have impacted this private-public model, right? And the doctors, especially, I think the chest specialists might have been more burdened with the COVID, and they might have been in more demand. So how has that impacted the maybe identification of TB cases, and what kind of things that you are able to do to kind of overcome those challenges?
It was very interesting because at one level, because of COVID that spreads through the air and coughing, which is similar for TB, there was a mass awareness of wearing masks and making sure that you cough properly. So I'm sure there isn't enough data now, but there is definitely some changes in transmission in the way people are hopefully coughing better now. On the flip side, of course, because during COVID, most of the non-essential services were stopped, and there were the provider base also had to start treating this new incidence of COVID patients or related illnesses. There was definitely a huge drop in the notifications, and even the provider going to clinics, many of the providers were shut, right? So I think that was for most part of 2020 when the pandemic started. Of course, we got better in 21 before the second wave hit. So I think the challenges were, how do you sustain service delivery? Because most of the systems were being utilized for COVID, not just the public systems, but also all of us partner organizations, INGOs, NGOs, we pivoted all our workforce to the pandemic response, supporting the government, whether it be oxygen delivery, management, or looking at the surveillance. So I think the change happened because there was some platform for engaging with them through these teleconsultations where doctors were working from home. I think that helped a lot in the private sector. And also the connect to the patients that happened through phone or through the Niksha setup where they would get an SMS as reminders, as Dr. Bhavna was earlier saying, because even most of the patients were not coming to the facilities. And then there were other changes that were made that instead of giving 1 month of drug at the center, you give 2 or 3 months of drug because you don't know when the next wave will come in. So those were some of the changes that happened. And I think the government also started bi-directional screening of COVID and tuberculosis, which was very important. So again, there were elements that the TB program benefited, but of course at the population level it had a major impact. And I think now there are in the next year of TB report you will see an increased number of diagnosis of cases, because the last 2 years we missed a lot of TB cases, and unfortunately they might have progressed to DRTB. That's yet to be seen. So that's the other side effect.
Okay. Thank you, Rishabh. So let me maybe let's look at the problems from the patient side in some sense, right? So when we are talking about the healthcare delivery model, so one is from the top down. How do we recruit doctors? How do we engage maybe private care providers? How do we kind of form partnerships with pharmacies, pharma companies, and so on? But on the other side is the crucial kind of the customer is the patient. So Jagdeep, I want to understand in your kind of when you are going and setting up these clinics, so what are the challenges you face in actually attracting patients, right? Because I'm assuming even at a nominal fee you're charging, but still, so me going to a pharmacist is going to be always cheaper, right? Because I'm just buying medicines. I don't even have to pay that 100 rupees or 150 rupees you may be charging. So, or if I go to like a non-qualified provider, so even maybe the charges will be way lower. So how are you actually maybe educating the patients in terms of why they should come to your clinic versus the alternatives?
Yeah, I think it's a great question. I don't necessarily have all the answers to this, right? Otherwise we might have, already been listed, right, a company. But I think, yes, I mean, there are, one answer to that is, consumer awareness, right? So we do run a lot of, community engagement, right? There is a lot of, effort that kind of goes into increasing the knowledge between formal versus informal providers in the community. This is a long-term strategy, right? So, I mean, it's not that people will change their behaviors overnight just because they are kind of this, right? So we actually approach this a bit differently, right? In which we have said that, okay, we are okay if for kind of, quote unquote home-based care, if you kind of, do your first consult, with a quack or with a pharmacy, because, that's what I also do, right? I mean, with that human nature, right? So we won't run to a specialist, right? If we believe the solution is not there. So, at least on a curative care delivery point of view, right? I don't think we are kind of challenging that assumption, right? In that sense. But what we therefore kind of now have, and when people now come to our clinic is because the moment that they feel that they need to kind of show to a specialist or a qualified doctor, we are becoming the first choice, right? So people actually come to our clinic after they have shown to a quack first time, right? But what we are trying to reduce is that instead of coming to us after showing to 3 different informal providers, can you come to us on the second piece, right? So thereby reducing the delay. And so that is one thing that we have done. And there are many cases where the informal providers actually now refer the patient to us that, guys, I think, you should kind of go there and see. So we have positioned our, our service offering a bit differently while we continue to do the outreach and the other things. But, I think, these are, long-term, approaches and, won't really have, an immediate impact, right, on that. So, yeah.
Okay. Thank you. So maybe kind of similar question to Dr. Bhavna here. So what kind of issues you are facing in terms of actually engaging with the patient, right? So you might be providing these services at the pharmacy level or maybe providing the education, but what could be some other kind of bottlenecks you might be facing in actually convincing consumers that this is important, right? So as you mentioned, maybe the symptoms are not there. So why should I even care about hypertension now? So even that 50 or 100 rupees I need to spend, what is the need for it? So if you can share any insights, so which is maybe convincing the patients to take that first step and start taking the medicine.
Yes, this is a very difficult thing. And if you think it's only a resource constraint setting, let me tell you, even in urban settings, the issues are the same. So basically convincing the patient to take medicine has been a challenge for communicable diseases and will be a bigger challenge for non-communicable diseases. And we have been trying various things because any kind of lifestyle modification for prevention of any disease takes a lot of effort. Simple thing we are trying for reduction of blood hypertension is reduce the salt intake in your food or utilizing a low sodium salt for your food habits. So whereby indirectly you are reducing the salt intake. So even for that, we are trying various models as of now, and we are very hopeful that we'll get positive results, and we will take those cues and work through that. So we have been working to various government agencies also. There has been we had made kind of programs where we can showcase to the public that if you take these preventive measures, or if you take your medicines, then the outcomes would be better. Showcase what are the outcomes first. That means you could get stroke and you would be incapacitated, and that really impacts the patient, and they start taking the medicine. If they've had any episode in their surroundings, in their areas. And one thing, after COVID, people are much more aware that comorbidities are very harmful. So that has led to a lot of awareness that we need to control and continue care for our comorbid conditions. These are basically hypertension, diabetes, or any cardiovascular diseases. So this has impacted, and to mobilize the governments also, public sector also, we need to keep up the momentum that if you reduce these comorbidities or control, you control and continue the care for patients, then the implications of infectious diseases are also reduced. So we need to really work on this. As you say, it's a challenge, and we are still working on it, but because we had worked on anti-tobacco campaigns. And just to give you an example of when we were working in malaria, I'd worked in malaria. What we had done is a simple booklet for children on mosquito biting leads to malaria. It had a major impact, and now malaria is going in for elimination. So educating at a younger level, educating through, we are thinking of educating through schools and other facilities. We are modeling these sort of studies, and once we are sure which would work the best, I think they'll be rolled out.
Okay. No, wonderful. So I just get curious. So do you think any policy changes at the government level in terms of maybe low sodium salts only should be made available? So have you explored any such kind of high level decisions, or is there a possibility?
Definitely, we have the first regulation whereby government has actually allowed a low sodium salt. So we are still, it is now technically allowed, and the companies can produce it and sell it. And the low sodium salts can go up to, these are all technicalities. Potassium can be added up to 35 to 40%, 45%, which is quite a good amount. And that will have an impact on your blood pressure levels. It's available. Many companies are making it there. But this is a very big challenge. That's what I said. It's very big challenge to change the way you eat. And that has to start at a very young level, and you need to inculcate these habits. But we are trying, and we are still under the process. You have to know that the normal iodized salt is subsidized. So the cost factor will also have an implication. They are subsidized in India. So we need to look at it from various angles. And we are looking at other fats. Somebody has written cholesterol and fats. So just to let you know that we are approaching this non-communicable diseases through nutrition also. There is a trans fat which is produced during the manufacturing of oils. And we have had a policy decision in India that all the industries will change their manufacturing processes and bring the level down to less than 2%, which will also impact the cardiovascular mortality, because it has been implicated in cardiovascular mortality. Various countries, developed countries, had reduced it over the last 10 years, and their cardiovascular mortality has come down. So we are looking at it from various perspectives. So one of the policy, this is a policy decision which has been taken, and it has been implemented through industry. So
Okay.
we are working to a multi-pronged aspect for hypertension.
Okay, thank you, Dr. Bhavna. So before I go to the chat and see the questions from the audience, my last question for Rishabh is like, I think it's already been touched upon in some sense, because the patients, especially for the TB, so they once they start taking the medicines, they might see a relief of symptoms, right? But I guess these medicines should be taken for a long time, like 6 to 8 months or so on. So what kind of interventions are you taking to ensure that this process is followed, right? So this is, I think this is a must in some sense, because the patient should be completely treated. And if not, there might be drug resistance that gets developed and which can have longer impact or severe impact on the society at large. So how are you addressing this issue?
Absolutely. Of course, the larger problem is, I think, research on new drug development. I think shorter regimens will really help. If I have a treatment for 2 months, I think some of them have been tried out in South Africa and we are trying some in India. I think that will have a larger impact. But of course, given that that is not there right now, these are hard antibiotics that we have to take. Right? So even if I am a TB patient and I get better, as Dr. Bhavna said, in 3 weeks, why do you want me to take drugs which will play with my stomach, lose motions, give me headaches, and all the other side effects? I think the most important part here is twofold. One is creating patient peer groups, like we've seen in HIV, that's been very successful. Because if you hear your peer, you will get to follow what he or she is saying. And the second is, I think, in whatever settings possible, make the family as a provider of care, not just the patient, because it's not just an individual choice, it's also a family issue. And provide that support system through counseling, saying it is important, it's for all of us and for your own good. I think those two are important. From a health systems perspective, of course, I just want to mention use of some technologies for those who are using mobile phones is something called 99 dots, which is being rolled out to the extent that 5.5 lakh folks have been using this. It's just an IVRS based mechanism to inform the system that I have taken my drugs, so that you don't have a healthcare worker visiting my home saying that you need to take drugs. And then the health worker focuses on the patients which need more support, maybe through counseling, saying, out of the 10 patients today, these 8 have confirmed that they have taken drugs. Through the system, I can see it on the dashboard. I will focus on the other 2 for either making phone calls or maybe even having face visits. But at the end of the day, it is not an easy treatment to take, and there are so many hurdles, and we hear so many patient stories, which is why empathy is very important, and being patient throughout the course of the treatment, as other speakers have mentioned.
Okay. Thank you, Rishabh. So I think we have maybe another 7-8 minutes. So let me take some questions from the audience here. So if you please share them in the chat box, or there is a Q&A button as well. So I'll go through them, and maybe I think we have time for maybe 2-3 questions here. Okay, one of the questions here is, people might be skeptical taking medicines and they may go around shopping from one place to the other, right? So in the sense, they might be economic pressures or something else. So you want to be treated faster. So I may go to a doctor first, and then if I'm not getting relieved from symptoms in the first day or second day, I may go to a second doctor. So maybe this is more relevant for Jagdeep. So how are you handling this?
Yeah, so I mean, in our case, we have pharmacy tied to our clinics as well, right? So when a patient, because again, our clinics are largely in rural India, and the doctors are specialists because there are not many other specialists in the same geography. Patients won't be able to find those medicines, that are prescribed in any pharmacy in that sense, right? So when we open a clinic, either we have our own pharmacy, or the clinic is actually right next door to another pharmacy, thereby ensuring that the medicines are being provided to the patient. So that's how we actually solve this, because again, ours is a very different case, because the pharmacist won't even have the medicines otherwise.
Okay.
And Professor, I just wanted to add one very nuanced thing that we found out when we spoke to multiple providers. They said patient expects to get better in few days because they don't have the time to keep coming to different doctors. So I will either give them stronger antibiotics so that they relieve the symptoms, or give them a lot of diagnostic tests. If you give them a lot of diagnostic tests, they'll say this doctor is, my expense is high. Just give me medicines, and I don't have the time to come to a clinic. So it's also, and that's how you see a lot of AMR related issues in India, and of course that has been also pushed ahead by the pharma companies. That there's sort of misuse of antibiotics, but it's also a way a patient will approach to a doctor, say, just get me well in a week. Don't tell me I have TB. So then I will not agree, and then I'll go to multiple doctors to reconfirm whether it's actually true or not. So I think it's a difficult one to solve.
Okay, thank you. So let me take one last question here. So even doctors seem to be reluctant to accept the AI, artificial intelligence or machine learning based tools. So any of you have an insight on how to overcome this challenge? Dr. Bhavna, maybe.
Educating the doctors, because we need to educate the doctors that this would be helpful to them. Most importantly, we are looking at one stop kind of a clinic. Why don't you think of a clinic which would be a continuum care for the family? Like we used to have general physician, family physicians. It could be a new model of working in the private sector, that you'll have a family clinic where the continuum of care will be maintained. If you look at pediatrics, it is there, but after pediatrics, we do not have this kind of setup. So if you could think of looking at a primary health care for family, and then the continuum care would be better, and the patients would actually come back to the clinic for treatment.
Okay, thank you. Jagdeep or Rishabh, any want to add to that?
Yeah, the way we solved it, right? I think initially as we started, we positioned it as this is a judge, right? And this will now, tell all doctors if their prescription is correct or not. And I think a few of them resigned as well, right? So the way we then actually looked at is to actually explain the benefit of this, right? And I think what worked, very well for us, that it can actually save some sort of a legal scrutiny from the doctor for the doctors, right? So if doctors are fairly rightly so a bit anxious about the legal regulations, the medical legal cases that could come in. So we have kind of positioned it to our doctors that there is an additional check that is helping you. So in case if you miss out something, this will actually help you to do that, right? So it is not intrusive, it is in a way supportive, and then I think everyone turned around to be to make it useful. So I think it's a lot on positioning, right? And I think the engineers out there probably won't even have the moral authority to actually question that, right? So we've kind of positioned it differently, and since then we haven't had too much of a challenge in that. Yeah.
No, I think that's very insightful. So I'm working on a project where we are providing artificial intelligence based tools to diagnose TB in X-rays, and the initial intake among the radiologists is very low, and it looks like clearly they are seeing it as a replacement or a competition to their own profession, rather than seeing it as a kind of a complementary, right? So that's what we are working on. So looks like I think your insight will be very valuable there. Thank you, Jagdeep. Rishabh, anything else you'd like to add?
Absolutely. Also, when we were doing this pilot with private providers in Nagpur, there was actually a protest by the radiologists saying, hey, you are using this computer-aided AI-based tool. Where will my job go? And I think we spent the next 4 or 5 months engaging with the radiologist saying, this is not going to replace you. But look, in settings where you're not present, it takes about 3 to 4 days to get the report. So there's a tool in front of the doctor. So I think that, as Jagdeep said, positioning is important. It is not going to replace doctors, but it will help you focus on something else which is more important, or sort of optimize your workflow. That becomes important. Once you do that positioning, it becomes easy. I mean, it's never easy, of course, because also some of the doctors say, I have this years of medical education, and now look, you're coming and telling me, a computer will tell me whether this position has TB or not. I'm not going to buy it. So I think that's the major challenge that we have to solve.
Okay. Thank you very much. I think really we had like 3 great perspectives. So we looked at from Dr. Bhavna on the hypertension, it's a chronic disease, and from a Rishabh's perspective of like management of tuberculosis, which is a communicable disease. And then we have from Jagdeep, we are looking at how end-to-end how we can provide primary care healthcare services in the rural and semi-urban areas. So I think we are running out of time. So let me hand it over back to Smita.
Thank you, Professor Raghram. Thanks for moderating the session and keeping it engaging and interesting with all the questions. Thank you so much. Thank you to all the panelists as well for your valuable insights. From the discussion and the experiences you have shared, we can all agree that the way going forward, in order to make healthcare accessible to larger populations, which is the focus of this discussion, any new model should be a collaborative effort between public, private, and the community. So we are certainly living in an exciting time in healthcare industry itself, and new innovative models are leading the way. And our best wishes to those of you, Jagdeep, Dr. Bhavna, and Rishabh, who are working in that space, so you can continue to make impact on more and more patients' lives. Thank you for being part of this discussion. So with that, we come to the end of the second panel discussion of the day. I welcome Jyoti Prabha Patnaik, a dear friend and a fellow student of Advanced Management Program of Healthcare at ISB. He is the learning champion for the class and by profession an associate director at United Health Group. I invite him to introduce the next panel. Over to you, JP. Good luck and thank you.
Thank you, Smita. Good evening, one and all. A very welcome to the third panel discussion of the day, themed as leapfrogging from traditional hospitals to digital-first models. What is that we are going to do in this session? As we know, advanced medical technologies, disruptive innovations, and digital communications are the new norm in healthcare. While digital care delivery existed in pre-pandemic times, COVID-19 gave it a strong impetus and paved the way for quick regulations, informed decision-making by clinicians, increased consumer adoption, and nuanced care delivery. In this panel, we'll discuss how traditional business, in the light of new competition, need to transform themselves. We have three eminent panelists, and it's my pleasure to introduce them for this panel session. First panelist, Mr. Prashant Singh, who is the Director and CIO for Max Healthcare Institute. Prashant is a veteran with wide domain expertise, built over 25 years in healthcare IT. He has provided technology vision and leadership in the development and implementation of an integrated and automated healthcare system. In addition, he has been instrumental in installing ICT setup in various corporate hospitals. The second panelist we have is Suman Katragada, who is the Global CEO for HIPS AI. Suman is an analytics thought leader with deep domain expertise in healthcare payers and providers. His experience spans across building data science capabilities to creating analytics center of excellence for large healthcare clients. He has been part of several complex transformation initiatives for reputed healthcare clients to use the data to generate actionable insights. The third panelist we have is Dr. Dhruv Joshi, who's a medical doctor and also the co-founder and CEO for Cloud Physician Healthcare. Cloud Physician is a healthcare technology company that remotely provides ICU expertise to hospitals that do not have access to ICU specialist doctors. Early in his career, he realized that technology can be a powerful tool to enhance quality of care and improve outcomes. In this role as CEO, Dhruv is responsible for managing the sales, growth, hiring, expansion, and strategic functions of the company. And needless to mention, we have three eminent panelists who have achieved significant success in their respective endeavors, and all that trying to make our healthcare system better. Professor Bijay Sundar will be moderating this session. Professor Bijay Sundar has really a long list of credentials. He's currently an assistant professor for practice and experiential learning program, chair professor at ISB. In addition, he is an affiliate faculty at Max Institute of Healthcare Management and an advisory board member at the Center for Executive Education at ISB. He's also a Six Sigma Master Black Belt from Indian Statistical Institute, PMP, ISO 9001 Quality Lead Auditor, and a Lean Facilitator, with an over of 18 years of industry experience across global corporate. Professor Bijay Sundar also holds PhD in Operational Excellence from IIT Madras, MBA from Sri Sathya Sai Institute of Higher Learning. He's also a gold medalist in his engineering from Anna University. He actively teaches specialized management courses for MBA and Executive MBA, PhD scholars, and business executives. He's research oriented and he's interested in teaching which include operational excellence, project management, operations and supply chain management, sustainability, digital information in manufacturing and service sectors. Like I mentioned, Professor Vijay Sundar has a long list of credentials, and I cannot think of a better person than him to moderate the session. Welcome, Professor Vijay Sundar. Over to you for the panel discussion.
Thank you. Thank you very much, JP, for that warm introduction. And once again, welcome all of you and a good evening to all. So let me start by saying this upfront, that the application of information and communications technology to provide digital health interventions to prevent disease and to improve the quality of life isn't a new concept. However, in the face of global concerns relating to aging, child illness and mortality, epidemics and pandemics, high healthcare costs, and the effect of poverty and racial discrimination on access to healthcare, the digital health platforms, health systems, and related technology-based business models continue to grow in importance, and they are here to evolve. We at Max Institute of Healthcare Management at ISB have been extensively researching on the topics related to digital technologies in healthcare. And today, I'm excited to moderate this panel discussion on leapfrogging from traditional hospitals to digital first models. So without much delay, let us jump on to ask some interesting questions related to this topic to the CXO suite panel members with us. We'll spend about 45 to 50 minutes hearing them on my questions, and you too can ask questions to the panel members. So please type your questions in the Q&A box, and I can pick them, a few of them, and route to the panel towards the end. So let's get started. Dear Suman, Prashant, and Dhruv, we look forward to learning from your views and rich experience. So here is my first warm-up question, and let me start routing this question to Dhruv. This is the fundamental question, and this is an interesting question as well to ponder to begin our discussion. Now, everybody is talking about digital transformation today. Dhruv, in your opinion, what do you mean by digital transformation? How should we understand this term to start the discussion?
Thank you, Professor. It's a pleasure to be here. Thank you, my fellow panelists and audience members. I think it's a good start to the discussion for the next hour or so. I think this is a frequently heard buzzword, digital transformation. We all talk about it, but what does it actually mean? It means different things to different people, but I'll tell you what it means to me. Right? Digital transformation in healthcare, to me, means how can technology be leveraged to empower the care that we provide. Right? That's really what the purpose of digital transformation should be, or at least is for me. Right? Because if you were to look at the status quo, if you were to look at what we have currently, we have caregivers and we have care receivers that are patients in healthcare, right? And if you look at how we function currently, you will find that neither one of them are actually empowered as much as they should be. You know, as a care receiver, as a patient, most patients in our country, and this is a problem across the world, do not have access to the quality healthcare that they need, that they deserve. Most patients, irrespective of where they may be located, do not have transparency in terms of the care that they receive. I'm a doctor myself and fairly well connected in the ecosystem, and yet when me or a family member or a friend or family member were to get admitted to a hospital, even I have a huge amount of lack of transparency. I have to call every connection that I can to try and find out what's going on, is the right thing going on, is it not, etc. Right? So that doesn't really empower patients, and that's a person who's as well connected as I am. Most normal patients who are not doctors or not connected to the medical fraternity are far less empowered to actually access the care that they need, or receive or have transparency in the care that they get. Then on the other hand, you have caregivers, again, who are not empowered, right? So even if you were to look at the last couple of years through the COVID period, you would find huge amounts of burnout amongst physicians, amongst nurses, and all sorts of caregivers in the healthcare field. Right? They were too few, they didn't have adequate skills, they didn't have adequate infrastructure. And so you would find that there were huge amounts of constraints, whether it is in terms of work-life balance. Now you have constraints with regard to documentation, unavailability of data when you need it, sort of restricts and constrains the type of care that we all sort of bought into this field to deliver. So you don't really have empowered patients, you don't have empowered caregivers. And in my mind, how can technology be leveraged to address these problems, right? All the way from access to care, to transparency in care, to easing the burden of caregivers, providing them with the access to the data that they need when they need it, providing them with all the information that they need, ensuring that they have some sort of quality of life, work-life balance, ensuring that documentation is adequate yet not burdensome. These are all aspects of digital transformation in my mind. So if you were to ask me what it means to me, I'd say, how can technology be used to empower the care that we provide? That's what digital transformation would mean to me.
That's great. Thank you very much, Dhruv. I mean, I think you clearly pointed and related digital transformation as an enabler to various things which are happening. One is pandemic. There are several social issues for which digital transformation could be an enabler to solve in the healthcare space. Wonderful, and thank you very much. Let us also hear the views about digital transformation, the real meaning, what you mean about it. Prashant, over to you.
Thank you, Professor. So as we all know, digital transformation is the most abused and most frequently used actually these days. Everybody is talking about digital transformation, whether it is related to network, AI, and whatever is the technology. So to me, basically what I understand from digital transformation, there are two parts, basically. One, the common definition, which can cater to any sort of industry. So how I define digital transformation is, so it's an outcome of IT, or you can say technology-enabled change aligned with business objective and driven by a well-planned strategy. Now, this is the definition actually which can cater to all sort of industry. Now, if it has to do its job for the healthcare, so since we are also from Max Healthcare, we are also driving a lot of digital transformation project. So for us, basically, we only categorize 3 objectives which would be coming from digital transformation. Maybe from the patient perspective, one is, of course, to improve the patient experience or engagement, we can say. That is one. The next is transforming operational processes which are involved in the entire patient care delivery. And the third is enhancing a business model or creating a new business model. If we take an example, in the pandemic also, I think everyone has already experienced a kind of digital platform which took care of virtual consult. So that was a small example of digital transformation actually, which did actually wonder when the patient was not able to come to the hospital and there was no connect between doctor and patient. So that was the area where actually digital transformation or the technology came to rescue this particular situation, and I worked wonder. Actually, everybody almost have experienced this. So similar kind of digital transformation, one have already experienced kind of online pharmacy is also another example of digital transformation. And if we were to take an example of non-healthcare workflows, basically, so Ola is also an example of digital transformation, where there's a set which is aligned by a business strategy, and perfectly it is an IT enabled system which is taking care of that particular business objective, which the technology might have foreseen that. So these were the few examples which digital transformation is related with.
Thank you, Prashant. I loved the way you said about the business models, the strategy, the keywords which are so important for business transformation. In fact, last year at Max Institute of Healthcare Management, we did a survey-based research where we had an opportunity to talk to many small and medium-sized hospitals in our country to check what kind of digital transformation approaches they take towards leveraging the technology today. Interestingly, we found that only 2% of the overall population that we spoke to, the sample that we picked up, only 2% of the hospitals said that they have a technology strategy before they jumped on to digital transformation. So that makes a lot of sense for us. We have more questions coming up to learn, to put this into a context and perspective for small and medium-sized hospitals. But before that, let us hear from Suman about his views on digital transformation.
Yeah. Doctor, can you hear me? Hear my voice?
Please go ahead.
First of all, I would like to thank you for having me on the panel. So before I answer this, the word called digital transformation, the definition of a digital transformation, I just wanted to give you a background in terms of what, at least in my experience, especially in India, what types of hospitals I have seen. There are 4 different types of hospitals that we kind of interacted with. And I would like to classify them into 4 different categories. The first is called the ignorance. The second is the naive. The third category are the thinkers. And the fourth category are the progressive thinkers. Now, when you talk about the ignorance, these are some of the hospitals where either they don't understand what digital technology means, or they are more comfortable with the old model of paper and pen. And at some of these hospitals, the word digital data or digital asset means scanning the documents that are either handwritten or printed and storing in their systems. Now, when you talk about the naive category, they usually have the HIS systems where at least some portion of the data across their units are captured either in structured or unstructured formats. But however, they don't have access to their backend data and have to depend or pay the vendor for any kind of data requests. Then you have the third category called thinkers. They have either the HIS systems, but at the same time are seriously thinking of upgrading to an EMR soon, or already have adopted EMRs with access to real-time dashboards, where they're having access to information, they're having access to insights, and eventually they're able to take decisions in real time. And then you have progressive thinkers. They are already on EMRs and established standards of HL7 for data sharing, security, privacy, confidentiality, and most importantly, they are in the process of exploring the advanced analytical capabilities. And I can tell you, the thinkers and progressive thinkers are not more than, I would say, 2 to 3% in the country.
Right.
Majority of them falls into the ignorance and the naive. And let me give you an example, what exactly it means, because most of them fall into the ignorance and naive. Let me give you 2 use cases. Let's take a physician and an administrator who are 2 different key stakeholders in a hospital. Let's say you have a cardiologist who is seeing at least 30 patients a day, and on a monthly basis, maybe around 750 patients at least. And at the end of the month, the physician wants to understand how many of their patients that he has seen are new patients versus repeat patients. This is a very simple example. I just wanted to, give you, what it means to have access to information in real time. Assuming that there is no digital asset or digitization of data in place, obviously the secretary would assist, go through all these papers manually, maybe after a day or 2, come back with the split. And the doctor might say, no, I think, the numbers are not matching as per my expectations. Can you verify one more time? And another day or 2 goes in, and then he has the information. Versus on the flip side, let's say the data is digitized and he has a technology platform and he has access to that information in real time. It's just a click of a button. Now, same with the administrator. He wants to have a revenue split across physician fee, labs, pharma, and others. So the same problem with accountants going through it manually and giving him versus getting access to this information with just one click of a button. Now, the reason I gave you these 2 examples is it's not to tell that clicking of the button is more important here. It's basically to say access to information access to insights, and eventually taking actions based on the insights are very, very important. The more you delay, the more you delay in taking actions, which is not good for them. So to me, if you have to sum up this, digital transformation is a journey. Okay, it's a journey that starts with creating digital assets and integrating those digital assets across all functions of the business so that the stakeholders are empowered to access information, generate insights, and eventually lead to taking actions in real time.
Right. That's great, Suman. I mean, interesting use cases, and thank you very much for sharing those examples. Now, it is evident that digital transformation has helped a lot of traditional ways of thinking to get into the mode of digitization or automation. For examples, there were health records before, and today we have electronic health records. There were long waiting times, queues in the hospitals before, and then today the digital technologies have helped reduce those wait times in the hospitals. There were prescription errors before or diagnostic lab errors before, and today digital has helped to kind of look at reducing all of them. Now, these examples are about existing ways of working, getting into the digital mode, which is great, which has a great value. But on the other hand, with digital technologies coming into picture, there are new business models that has evolved. Not about automating or digitizing an existing way of working, but creating a new business model altogether. For example, today we have telehealth, and the telehealth models have created new revenue streams for many of the healthcare firms. On these lines, if I have to go beyond enabling process improvements, how is digital transformation changing the traditional business models? And let me ask this question to Dhruv to share some examples of business model innovations that emerged as an outcomes of digital transformation today.
Thank you, Professor. So I would, lean on something that is closest to me is the work that we do. I lead a company called Cloud Physician, and we are remotely helping hospitals manage patients in their ICUs. Now, we know that this is a huge problem, irrespective of which country you are in or which geography you are in. And ICU is the place that has the sickest patients, and patients that can, whose outcomes can change in a matter of seconds. So it requires rapid response, early proactive monitoring, and ensuring that standards and processes are followed to the best possible degree. Now, without being digital, doing that is going to be very challenging, right? So I think what we have been doing at Cloud Physician is we have been, I would say we started a few years ago, but we started with the low-hanging fruit, understanding that, hey, you know what, we can make the maximum amount of change in places that have the biggest problems. And so we started with small and medium-sized hospitals, helping them manage their ICU patients. Right now, this enabled the consultants, this enabled the surgeons in these hospitals to have the confidence that the patients that they were admitting here were being managed as they would be managed in any other larger hospital or in any other larger city. Right? So that was the sort of change that we were able to bring about. Now, this can be transformational for a small and medium-sized hospital, right? Because the problem statements that they face are typically related to many of the things that we talked about. The quality of the care that is delivered in these hospitals, the perception that the small and medium-sized hospital has in being able to address the needs of its community. And so community members tend to veer towards, branded hospitals or corporate hospitals, or, and in scenarios where you're critically ill, you don't have the luxury of doing that, or you may not have the financial luxury of doing that. So enabling these community hospitals to sort of become centers of excellence in managing their critically ill patients, addressing the critical care needs of those communities, has allowed those communities to access care, has allowed that hospital to develop its services, whether it is around its consultants, whether it's around its surgeons, to expand the scope of what they can perform, what they can do in a small and medium-sized hospital, and sort of make that a model. Because let's be, I think we will all be in agreement that if you're looking at secondary and tertiary care delivery, it is not going to be possible for us to construct ivory towers of traditional ivory towers of excellence in every place that it is needed. Yet the care is needed, right? So the only way that you can create a viable business model is by leveraging digital here. Now, I would go to the extent of saying that in many of these hospitals where we have been able to pervasively digitize, pervasively have, and some of these hospitals are small, medium-sized hospitals that you would not typically associate with the huge levels of digitization, right? But the hospitals in which we have been able to achieve this, we are achieving outcomes that are comparable with any large standard of care corporate hospital that you would typically imagine would deliver those kind of outcomes. So what we're trying to do here is we're trying to ensure that a patient in a small, medium-sized hospital can get the same outcomes as that patient would have received in, say, a large corporate hospital nationally or internationally, right, for that level of disease that can be managed at that hospital, of course. And now that can be transformational because you're now ensuring outcomes that were traditionally associated with very high costs, and you're doing it at much lower costs, right? So it's only a matter of time that a model like this would sort of find its way into more mainstream, irrespective, utilized by everybody. Because if you can deliver the same outcome at a lower cost using technology, then that's the way to go, because we all know that healthcare costs is a huge problem. So I'm just giving you one example of how some of these business models are going to sort of move from the fringes to more mainstream as we see some of these outcomes coming through.
Very true. I completely agree with you, Dhruv. In fact, while talking about the larger picture of the social impact that the telemedicine, the related business models can create, of taking the healthcare to the rural parts of the country, where today, which does not have access to the big, or even one is affordability and second is accessibility to the big corporate hospitals. So from that perspective, this sounds great to me, but I would be interested also to hear Prashant's views on this, about some thoughts from you, Prashant, on the business model innovations that are emerging because of digital transformation.
See, everybody is talking about telemedicine. So telemedicine is not a new technology. So we have been using for a long time. But the realization, more realization has come in the pandemic time, when actually the use of telemedicine has increased a lot. So that is a clear-cut, new business model actually, which everybody is talking about and everybody has realized from that quarter. At Max Healthcare, there is a vertical called Max at Home, wherein we provide a lot of home care services, for the patients, which includes the critical care nursing, remote patient monitoring, and things like that. So in pandemic, actually, we also realized that by the use of digital transformation or the technologies actually which we leveraged there for the patient remote monitoring, specifically for the home isolation packages actually which we launched during the pandemic. That is, that gave us a kind of new business model from the patient remote monitoring point of view, not from the isolation, but also from the patient remote monitoring point of view. So that is the reason actually we are leveraging this particular technology and taking it further to create a large digital platform actually, which take care of, along with the patient care monitoring, we can also take care of, a lot of ICU care and remote monitoring using the same technology, and also the online pharmacy actually, which we will be leveraging with the same kind of technology. So there are a lot of business model actually, as I've just mentioned regarding the at home kind of services basically. So these are the few of the technologies which we are actually leveraging.
I understand. Thank you very much. That's interesting. I mean, yes, I do agree with you that telemedicine is not a very recent concept. It has been in bits and pieces, and then it was emerging, but the COVID has made it more important and more usable or more frequently used in the last few months or past few years. But this also brings us to another important question, which I would like to ask Suman, about the frequently used applications that enable the digital transformation towards creating the digital first models. So Suman, how to objectively identify the applications for different segments within healthcare? Your views, please.
Yeah, so couple of things. Every model, I mean, like Dr. Mr. Prashant said, every organization has different goals and objectives, right, to achieve. And like that, if you think from that perspective, every technology platform that you use has to either meet those goals and objectives, or if they're not meeting, then technically it's not on your chart, right? And there are certain points to kind of validate, whether it's meeting your goals and objectives. Point number one, how is it going to add value? Is it going to increase your top line? Or is it going to reduce your cost of care? Or is it going to increase accessibility to patients? Or is it going to provide better experience to patients? And number five, what would be the execution complexity that is involved to enable such an initiative? Okay, and the most important thing, the change management aspect of it, will my team be positive to adopt this kind of a platform? If you evaluate all these things in these 5-6 dimensions that that I mentioned, and come up with an objective assessment of each of these dimensions and see if that is what exactly is driving the value to the organization, I would basically say, out of the 10 ideas you have from a digital models, if you run with this objectivity in mind, you will end up with 2 or 3 that makes meaningful sense to you.
Interesting point, Suman. And I love the way you said about change management, and I can relate this to some of the research. And the research says that 70% of digital transformations fail because of lack of change management. Now, change management is an interesting topic, so I would like to hear from all three of you. Maybe if I can start from Prashant, what are the critical aspects of change management, Prashant, in the context of digital transformation? And when I mean change, it's not just about the people alone. I'm talking about the whole ecosystem of people, the processes, and the existing technologies in the healthcare firms together as change management.
Yeah. As we just mentioned, actually, when we are talking about digital transformation as a project, so there has to be a clear goal, basically, for which you are actually doing that particular digital transformation, and that can be a business goal or some kind of operational goal. So the first point actually which comes in my mind from the change management perspective is it has to start with a clear and thought through vision of the board and management. So my experience says basically it has to come from the top, basically, and the vision and the mission should be absolutely clear why we want to do this. From that point of view, it should start with that particular vision, and then going further, we should be very, very clear that what kind of investments which are actually required to achieve that kind of project. From that is also a big change management from the investment point of view. So that is number 2, basically. So going further, it has to be a well-defined strategy on all the stakeholder engagement in order to have the buy-in from all of them. Because ultimately, when you're implementing some kind of project, so every stakeholder is absolutely equally important, whether it is small or big or medium, whatever it is. So that is how you achieve the success when the project is being rolled out. And actually, because a lot of the projects you just mentioned that actually fails because of some weak link in the entire chain. and that may be, one of the stakeholder management which was not engaged in that particular fashion, which it should have been. So that is, number 3 actually in that row actually, which I feel. Then when we are only talking about technology, the change management will not be only the responsibility of the technology. There has to be a lot of alignment with a lot of operational process changes also. Like, for example, when I'm talking about, patient remote monitoring, so there has to be the alignment at the back, basically, that, whenever there is a, requirement which comes to the hospital, which is the team actually which going to actually handle it. So, for example, I'll give you a small example also. Like, we are also thinking of, starting an instant doctor consult. So there has to be a complete process change at the back. Basically, there one has to have a kind of command center to cater to all these kind of critical requests. So that is on the alignment of the processes, operational processes change. Now about creating new processes to cater to the new business model. When we are actually talking about digital transformation, so it might attract a new business model. For that, a complete new process has to be actually written and to be understood. So that is point number 4. So going further, basically, and it has to be a complete cultural shift. Drive has to be there, so that the involvement right from the top to bottom, actually everybody should be there, and there has to be a complete engagement from that particular thing. Like, for example, now I'll give you a small example of teleconsult also. So we did a small survey wherein we asked simple 2 questions to the patients, that are you happy with these kind of setup where you are interacting with the doctor virtually? Number 1. Number 2, if this is launched during the pandemic time, post-pandemic, do you want to continue with these kind of services? So at that point in time, 70-80% people said that, okay, this is a fantastic service and we are happy with the service and we would like to continue this kind of service even post-pandemic also. So what I have observed, once the pandemic is over, so where the virtual consult was in the tune of say 25% of the overall consult, it came down to 2%. So now the point comes, which I'm just, talking about, is the cultural shift. Maybe I think some cultural shift has to, come from the doctor side also, so that doctor can, even if the patient is coming for the first follow-up, doctor can actually guide the patient that, okay, so this can be done on the virtual consult also. So this is a very important, factor, from that particular change management when you're driving a project for digital transformation.
Right. Thank you, Prashant. It's interesting to note the statistics from your survey. A huge dip from 25% to 2% post-pandemic seems to be an interesting measure. We would love to touch base with you more to learn on the research aspects behind this survey, but let me route the same question to Dhruv as well. Dhruv, from a cloud physician's perspective, from a telemedicine or a telehealth perspective, what do you think are those aspects of change management that we should be mindful of?
So any system, Professor, when I think about it and sort of break it down, you break it down into people and the design of the system and the people, right? And when I say design, I mean everything from the culture to the leadership to the messaging, to the team, to the technology, to the existing technology, etc., etc. And then you have the people on the other hand. Now, in healthcare, usually you do not have the luxury of changing people, right? Even if you want to do a digital transformation, at least at the front line, the people that are going to be using it, whether it's the patients or whether it is the providers or the doctors, nurses, those are constant in most cases, right? In the majority of cases, I would say. So then it comes down to the design, right? So how do you create a design where you want digital to be a part of this design and work with the same people, right? And it's complicated stuff, as you can imagine, right? And so there you sort of have to think of it holistically, and I would sort of second some of the things that Prashant talked about in terms of, number one, understand where the priority lies. The priority always comes from the top, right? So at a leadership level, assigning the priority, then providing the tools for the people to adopt, all the way from cultural change tools to the technology that you actually are implementing, and how that sort of is designed to work with the people that you have, with the processes that you have, how the technology is designed to work with the existing technology that you have, or you're going to continue to use or integrate or discard, however that may be. So, and there's the entire sort of, training, onboarding aspect of it. So in our context, that's typically how it is, right? So when a hospital is signing up to digitize the management of its ICU, the people are going to remain the same, right? You're not going to get a whole new set of doctors and nurses. So then you sort of work on the design around the people that you have. And that design is working with the leadership to get the messaging, right? Getting the appropriate technology, training, onboarding, constantly skilling, building rapport, and enabling that cultural change to take place. These are all aspects that are part of the solution. It is not, here's your technology stack and go for it. Nothing's ever going to happen with that. Right? So until and unless this entire design around the transformation which you're hoping to achieve is not sort of operationalized and executed, you will find, like you mentioned, the numbers that most of the digital transformation fails, right? For these reasons. So it's complicated stuff, but in our field at least, this is what it comes down to: aligning with the leadership, getting the messaging right, building bridges, getting the technology and designing it for the users, ensuring that you sort of build buy-in, building relationships with the users, and enabling that cultural change, show them how this is in their benefit, in the benefit of the patients, in the benefit of themselves and their colleagues, and constantly working on training and reskilling in different ways, in however you can. So that's some of the, I would say that the technology aspect of it, if you look at it, is a small component of what I'm just describing. So the technology is really, as complex as it may be, it ends up being a small part of what you need to do for this digital transformation to happen.
Right. Thank you, Dhruv. I completely agree. Both you and Prashant resonated the word culture there, which is more important to kind of set right up front before even we embark the digital transformation. And of course, it's a journey. It improves over the time. But I have a follow-up question for you, Dhruv. In a response to earlier question, you briefly spoke about small and medium-sized hospitals. Now, connecting back to this question of change management. Now, small and medium-sized hospital segment is altogether a different segment compared to the corporate hospitals, right? Because one, the risk-taking appetite may be low, the resourcefulness or the budgets may be less compared to what corporate hospitals could be. So it's a different landscape that we're talking about in medium-sized hospitals. Now, how do you think small and medium-sized hospitals should prepare themselves for the transformation journey, the digital transformation journey? If you can give us 2 tips from your experience, that would be very useful.
Thanks again for that. Yeah, I completely agree. I think, one thing that we should realize that the digital transformation, I think, is perceived to be a big hospital or an enterprise sort of undertaking typically, which frankly, if we want to address some of our larger public health needs, should not be the case, right? Because when you think about it, you would find that enabling a digital transformation in some of the small to medium-sized hospitals, which cater to the vast majority of our population, would really ensure outcomes to sort of reach out to a much larger set of people. So I think just for us personally, we've sort of made it a part of our mission to drop the barrier for this digital transformation or adoption of technology, and so we cater to a lot of small and medium-sized hospitals. There are pluses and minuses to that, right? Of course, you highlighted some of the challenges where they're not typically already sensitized to perhaps the power of digital. There may be limited budgets, so you create digital solutions that are not necessarily as heavy. But I would say there are some positives as well, in the sense that typically in some of these places, decision making is not as fragmented, right? So if you are able to align the right decision maker, your digital transformation journey can actually happen much faster than it would happen in a larger organization where you have far more fragmentation of decision that takes place. And that has been our experience, right? So, but also goes back to, some of the attitudinal description that Suman had talked about, the 4 types of people. So if you're able to identify or convert the people into the right attitude, you can find, or the right decision maker into the right attitude, you can find digital transformation take place much faster in a smaller organization than it would in a larger organization. Right? So that has been an experience, and that's something that I would anyone else who's looking at that space, I would sort of give them that as a tip.
Okay. Thanks, Dhruv. This is an interesting point. I know that when we talk about the digital first models, there is a lot to learn, not only from the healthcare to healthcare kind of knowledge sharing, but we can also learn from other industries where digital transformation is happening today, isn't it? So for example, I know in Max, Prashant may agree that there are robotics process automation which has happened. And that has been a good success story for Prashant to share. But Prashant, if I were to ask a question related to learning from other industries, I mean, in your opinion, what can healthcare learn from industries like, say, other services like banking or financial services or food and hospitality for that matter? What are those lessons that as a segment or as an industry, healthcare can learn in the context of digital transformation?
See, first of all, there's no match, as compared to healthcare with banking. Actually, there are many ways. Although the vision of digital first model is already there, but still I feel that there's a long way to go. Like, for example, there are, many workflows actually, which, patient has to come to the hospital only, and there is no digital first model. This is personally, my feeling. Like, for example, there are few scenarios which are absolutely clear and you can actually adopt the digital first model. But there are scenarios like, for example, in case of emergency and some emergency procedure, surgery, you have to actually travel to the hospital only. And it can't be managed at home also, even if you have the patient monitoring and a lot of other technologies to actually help in that particular fashion. But as I've earlier mentioned, that if there has to be a vision basically in terms of whatever processes which are already there and which can be actually automated using the digital technologies. The vision should be, if the vision is clear, I'm sure that we can achieve that. The RPA example, like for example, you have given. So RPA is a technology. Now it depends actually what kind of usage you have actually envisaged and you're using that particular technology. If that thought is absolutely matured and clear, I'm sure technology would give the positive result. Similarly, when we are actually talking about digital transformation, so we are talking about a bunch of technologies. Just to give you one example, like for example, cybersecurity. So cybersecurity is the very, very important base on which the digital transformation works. So you have to have a robust cybersecurity plan also, so that whatever you are building, it should actually sustain properly. And similarly, for example, technology like low code, no code. Now, for example, in that digital transformation journey, if you require to automate one single process, it should not take longer time. So we are already using low code, no code platform. The moment actually we have a requirement from automation of that particular process, hardly I have seen that it takes 7 days to actually automate any kind of collaborative process, wherein actually you are capturing the data, collating the data, and actually giving it back in some form of analytics or visualization. So in total, actually, when we are actually talking about digital first model, so everything needs to be considered that way. That is my take basically.
Okay, so you mean to say that there are some lessons that we can learn from other service sectors, but that has to be restricted only to the non-clinical processes, because the clinical process have no other choice than to have the non-digital ways of working. Is that what you're trying to say, Prashant?
No, so slight deviation basically. So there are a couple of clinical processes that can be completely taken care by digital first models. But when it becomes emergent as a situation, basically, then it can't really work. You actually need to see a physical body, that from that point of view. That is what I meant to say.
Okay, so I can visualize a kind of a 2x2 matrix as you speak, one on clinical and non-clinical process, and the other one could be critical and non-critical requirements. And the box, the quadrant which says clinical and critical is something which you mean to say the non-digital ways of working has to be still more applied there. That's great. Yeah. Thank you very much for that clarity, Prashant. But let me also ask Suman about this. Suman, I know that we cannot compare healthcare apple to apple. It's not a right comparison to make with another industry like banking. But is there something that we can learn from other industries with regard to digital transformation that we can learn from healthcare context?
Of course, see, as Mr. Prashant said, we're always behind. We're not as matured as the banking industry or the insurance industry, or to that extent, even the retail industry, right? We are probably, I would say, 5 to 10 years behind those industries in terms of adopting the digital technology platforms. And I feel that I don't see that we will even do a comparable role maybe in the next 5 to 10 years. But the relative growth in healthcare from the digital first models perspective, I see that very high in healthcare, because the more people adopt the digital transformation journey, the more people will have access to information, more access to insights, which eventually will lead to a lot of innovations in terms of the new ideas coming up, in new ideas on the digital fronts. Now, like for example, I can tell you one of the things that we have done at consumer goods industry, we were able to apply in healthcare. Okay. Now, this is a problem that probably might be interest to all the hospitals. This is a problem, like leakage is a big problem for hospitals, right? But we don't talk about it because we never know, we never measure it, right? So we don't know anything about our patients post their encounters with the hospitals, either in the OP or IP. So usually out of 100 patients who come to the hospitals, 90% of them, at least 80 to 90% of them are chronically ill, having one or more chronic conditions. And that by nature of these conditions, they are supposed to see their physician at least once in a year, right? And also they need to be on a continuous disease management plan. If you look into your records, you will see not more than 30 to 35% of these patients come back the following year. Now the question is, what is happening to the rest of the 65% of these patients who are not coming back?
Right.
Now, some surveys we conducted, we found that approximately 40 to 45 to 50% of these patients mentioned that they just forgot. Okay.
Interesting.
About 20 to 25% of these patients moved to the competition. And the others had other reasons, which technically is not very important here. But what caught our attention is this 70 to 75% of these patients saying either they just forgot or moved to the competition. Now, most of these problems are behavior related, right? And if you go into the reasons of what led to the forgetfulness, it is quite obvious that since the hospital did not engage with patients since their last visit to the hospital, it was not on top of their mind. And lack of continuous education awareness led to forgetfulness. And even on patients who move to competition, the root cause of the behaviors is the same. So when they needed care, they were influenced by their neighbors, family members, because there was no engagement going on with the hospitals. So one is very important for hospitals to maintain this continuous engagement through proactive risk assessments, education, awareness campaigns, and all. I'll just give you a small example that we have done for a 300-bed multi-specialty hospital here in India. They want to control patient leakages to maximize the top line and bottom line. Fortunately, the hospital had an HIS and are looking for the right vendors to implement an EMR. They have created their own digital assets and have access to them, though most of the data is in unstructured formats. So what we were able to do is take the principles from the retail consumer goods industry and first help them to integrate the data assets, create a longitudinal view of each patient, extract all relevant fields from the structured text, and assign severity scores. Okay, some kind of a severity scores based on what is the expected resource consumption of this individual in the next 1 year. Based on that, you assign a score. And at the same time, you stratify them into some high, medium, and low risk groups, right? Then you develop a system with the care management plans based on their condition severity scores. The touch points and clinical questions were customized, for each of the groups. The idea is to keep focus on high and moderate risk patients because they're the highest contributors. You can't afford to lose them.
Right.
That doesn't mean that you can afford to lose the low risk category. Right? So usually these are the folks who majorly flood the hospital lobbies. Right? So the idea for the low risk group is, can we come up with an alternative delivery plan, such as telemedicines, or can we do proactive risk assessments, or through home care delivery, address the needs so that they get the right care needed at their doorstep. Now, you focus on the moderate and the high risk guys. Of course, they need to be on remote monitoring. They have to be on continuous care management plans. And there need to be a proactive risk assessment to understand proactively who are the patients who require this clinical intervention from the physicians. Right? So the more engaged you do from a clinical perspective, from an education perspective, and from an awareness perspective, the more you have patients in the control. Because most of the hospitals that we've been working with, and we've seen across India, we spend a lot of money on marketing, right? Without knowing what the end ROI is.
Absolutely.
This is one of the best ways to actually figure out an ROI.
I agree with you, Suman. I mean, this is an interesting example, and thank you for sharing that. Both Suman and Prashant, I think you brought great perspectives about what can we learn from other industries, and specifically this example on consumer goods industry that we can leverage to look at the assets, the consumer data, the patient data for a longer time, awareness creation, and understanding the patterns of data behind. This is a great example. Now, let me ask Drew another question related to this. I know some of the panel members mentioned that telemedicine is not new. And then COVID has accelerated the digital transformation journey, which is something most of us would agree with. Now that we experience a black swan event in the form of COVID-19, it is evident that digital has a great role to play for the future. Now, Drew, if we were to face another pandemic tomorrow, how should the healthcare players prepare themselves?
Thanks, Professor. So I think that's an interesting point, and I think this entire 2-year period that we've had, and I think we mentioned some numbers of how the adoption of digital went up and it came down, which was, I think, what most of us had predicted at some point in time. But I think what it made clear to us was that in a scenario like this, it is digital that's going to perhaps scale at a much quicker and much faster rate than any other way. If you're going to look to get access to care, it will have to be digital means. While that may have been clear, I think people who will also sort of see through the fact that this was just a sort of primer to how you can make systems. Now, I think the expectation that you will go from 0% to 25% of usage on a consistent, sustainable basis in a few months' time is unreasonable an expectation. It happened only in the setting of like extreme circumstances, right? That should never have been thought to be sustainable because of the reasons that I told you about. That digital transformation requires another change in design, all the way from cultural changes to making sure that technology is appropriate, to making sure that all of those things, and you can't do that in 2 months or 3 months or in the beginning of March and hope to get it done by April or May. So I think while we are seeing an uptick, in many ways, I don't think that this is unexpected in any ways, right? We still need to do the heavy lifting and the hard work of changing that entire design to allow digital to become mainstream, which is the way that it has to be, right? I mean, even when we talk about other industries, or we talk about critical situations, for example, where people say that, hey, but digital doesn't work in critical. That's interesting. That's something. If you look at the comparable industry like the airline industry, it's digital, right? It's the most high critical situation that you could think of, and all your while you have a pilot at the helm of that airplane, he is supported by as much digital as you can think of. He has an ATC and all the other paraphernalia that's constantly tested. It's not people based, right? It's digital based. And so I would say that's perhaps what you would want eventually to be in an ICU, for example, right? Where you sort of prevent things from happening before they actually happen, before you need the physical body, or for that matter, if you have a critical situation in one bed where you have the physical body of the doctor there, and you have something at the other bed that happens simultaneously, how do you solve for that? If you have a digital mechanism where somebody can at least support a nurse or a junior doctor, etc., you're going to solve for some of these problems. So I think we will find over a period of time that if we are going to, and I'm giving you like the high end situation, but there's the entire aspect of just getting access to care, which and telemedicine in my mind is a small fraction of digital, right? I think we all understand that it's a very small fraction. And I would say even within telemedicine, in fact, there would be an entire sort of spectrum where you have just chronic care, or you have teleradiology, to all the way to where you're sort of doing telecritical care, which is what an ATC of an airline may be doing it to some extent, if you were to look at comparisons. So I think to your point, Professor, what we will find is that as we move towards building more robust systems, we will find that that going the digital journey in whatever shape or form, and obviously it will have to be customized, it will be heterogeneous, but it will be the way. And so if you were to ask me what we should do, I would say that we should start creating some sort of a roadmap to moving in that direction that would help us be in a better situation if ever we were to find ourselves in another black swan situation like we did in the last 2 years.
Right. Thank you, Dhruv. And you brought in another interesting perspective that it's not the quadrant which we spoke, which is clinical and critical. It is also in scope for digital transformation. That's the point which you articulated. And I have to agree to your point, because I remember last year, Professor Sarangdev and I had an opportunity to write a case study about cloud physician, how tele-ICU has created a big change in a remote village in our country. So I cannot disagree with Dhruv's point on this perspective at all. And thank you, Dhruv, for your suggestions about how should we prepare if we were to kind of face another black swan event in the future. Now, let me stop here and look at some of the questions from our spectators and audience here. So here comes an interesting question. This is something as an extension to what Dhruv just spoke about. So let me route this question to Prashant. Prashant, so here is Dr. Birendra, who asks us, some thoughts on the role of players in the patient care via digital transformation. Now, Dhruv spoke about the entire ecosystemic design has to change. The change has to come fundamentally in the way we think. Now, I think this question is more to do with another important stakeholder in the bigger ecosystem of healthcare, the payers. So thoughts on role of payers in patient care via digital transformation.
Yeah, so there are a couple of learning actually from the pandemic and the digital transformation which happened during that pandemic time. So the new platform actually at Max Healthcare, which we are building right now, so we are also taking care of a lot of integration which is happening between hospital and the insurance companies also. Of course, actually we are finding a little challenge in terms of, like, for example, there are many payers actually which doesn't allow you to integrate with your digital platform through some APIs or things like that. So there are a multi-pronged approach actually which we are taking in terms of use of RPA. Wherever it is, wherever the API is available, we are consuming API. Wherever API is not available, only the web access is available, then we are actually leveraging the robotic process automation. So this is the way forward, and we can go like that only.
Okay, thank you very much, Prashant, for that response. We have another question from an anonymous attendee, and the attendee routed the question directly to Suman. So Suman, let me read out the question for you. As a promoter of AI algorithms, what platforms do you leverage to reach out to hospitals? I'm reading only the first part of the question because the second part seems to be a little tricky. So let me avoid that. The first part is, what platforms do you leverage to reach out to hospitals?
I mean, in terms of the sales, I mean, I'm
in the terms of promoting your AI algorithms that you use.
Of course, my point is not from a platform perspective, because it's a direct interactions that we have with the decision makers at most of the hospitals. Point is, first, we need to kind of explain them, or at least in my experience, I can tell you that when we started this Heaps.ai, we didn't have good adoption, to be honest. Okay. The reason is we are working with multiple players. We are not working on behalf of hospitals. We are not working on behalf of insurance companies, but we get money from both. Okay. We work on behalf of patient. And there's a conscious reason why we do this. One, as a care management and coordination entity, if I take the side of a provider, then the provider's incentive is on utilization of services. The more utilization of services, the more money they make, which may not be, which can be a counterintuitive to a patient or a payer. But from a payer's perspective, if I take a side of the payer, the lower utilization makes them win. So technically, it might not make sense from a patient perspective. So that's the reason why we take a middle path, where we take from a patient perspective and say that, we are here to help you to optimize care without compromising on quality of care, right? So for us, it's all about, when you monitor the patient, when you track this patient, the entire journey end to end, what are those events that are leading to complications? Are there early signs that you can watch for and track and record them? And does the system understand whether does the system understand, or is system capable enough of understanding whether a symptom given a certain condition or a group of conditions or a list of conditions that the patient has, is this something that needs to be escalated to physician for clinical intervention immediately, right?
Okay.
So now when you position yourself like that, but still you expect money from hospitals and insurance companies to come in, and you don't take a single penny from a patient, obviously the intention gets questioned, right? So it first started with educating a lot of stakeholders at the leadership and the management level. And we made inroads into the hospitals, but developed the technology for insurance. Okay. Went to the insurance, got almost, I would say, 70% of the private players right now on board. And now we went back to the hospitals and kind of, getting more hospitals on board, right? So yes, first it started with education. So that's the reason why I always say that, if I meet the decision maker at the hospital, if he doesn't understanding most of the times, maybe the lower level doesn't understand. There's no point in wasting my time there. So, so we just directly go to the decision makers. So that's how we do. And there are two major platforms that we offer. One is helping them to establish the quality of care, because this is a question that we always debated, even when I was at PwC US, leading the healthcare strategy and the area of practice. Is it revenue first or quality first? Okay. And at least the organizations where I have seen who voted on revenue first without fixing their quality eventually lost the game, right? And there are institutes which they said that, we make impact on quality. Quality is the top-notch thing. We don't compromise on quality. They have established steady revenue flows. So revenue automatically followed. So I come from the same school of thought. So for me to work with hospitals first, I basically see is the vision aligned? Are we focusing on quality? Yes, if it's there, then technically you help them to track the patients post-hospitalization, record their outcomes, and basically understand the root causes of bad outcomes, fix it, and then take it back to the insurance companies and tell them, hey, they have demonstrated quality care and at optimized cost, and they deserve to be incentivized.
Agreed.
Right? Agreed. You change the payment models from fee-for-service to value-based care. So it's a long journey. It has been, I would say, I won't say stressful. I would say happy journey for the last 4 years, with a lot of learnings down the play, because we have a vision and there are n number of paths to achieve that vision, but we want to follow a path where our presence in the system becomes very, very important.
Right. Thank you, Suman. That's a wonderful that's a wonderful way to respond to this question, and I completely agree. I can echo with some of my experience in the field of quality as well, that once we look at the revenue from a customer acquisition perspective, I mean, using the word customer in healthcare may not be complete meaning, but if we focus only on the customer acquisition side of it, of course, the revenues may increase. You may, as an organization, we may get a competitive advantage, but to sustain that competitive advantage, the quality has to be an enabler. So I completely agree with your thought of the big role that quality has to play in this game of digital transformation. We have more questions here in the Q&A box, but for the interest of time, I'm not going to ask all of these questions. We got to know who is that anonymous attendee, by the way, Suman. It is Megha. Thank you, Megha, for that question. I can see Yamunuddin and a few others here have put some good views about it, but there is no question there. So I'm not going to ask to the panelists, but I appreciate putting your views here in the Q&A window. So just to sum up, I have some key learnings that I have made a note from this panel discussion. Personally, it was a great learning for me, hearing the rich experience of all the three panel members. We spoke about the top line, bottom line, clinical, non-clinical, critical, non-critical areas, which will be good candidates for digital transformation. Dhruv also brought the point of how digital transformation not only help building the top line or bottom line for an organization from patient experience or operational excellence perspectives, but also from a social impact or building the healthcare infrastructure for the society in large. We also heard Suman classifying the entire players here in the market into 4 categories: ignorers, naive thinkers, and progressive thinkers. I made a note of that, Suman. This is wonderful way of classifying the players here. Prashant also spoke about some use cases, some examples of how technologies can help and benefit organizations, especially in the small and medium sized hospitals. How can the digital technologies play a role towards embarking the journey of becoming digital first models? So thank you very much. I enjoyed the discussion, the keywords being the culture, strategy, impact, and change. Thank you very much, all the panel members. So let me hand over the show back to JP.
Thank you. Thank you, Professor Bijay Sundar, for moderating an exciting session. The panelist mentioned healthcare is complex. While you cannot have right comparison with other industry, we can still learn a lot those industries, how they have matured over a period of time. And rightly, like you have summarized some of the great insights which we heard. But the key words like leadership vision, organization culture, and appropriate change management methods are key to reap maximum benefits from digital transformation initiatives. Yeah, and Dr. Dhruv also mentioned digital transformation yields better outcome even at lower cost. Certainly, I mean, digital transformation is not new. It was there earlier in pre-pandemic time also, but only in the pandemic times, people realized the true potential of digital transformation, and it is going to stay here again in the post-COVID world as well. Thank you, panelists, for all your valuable insights. We learned a lot out of this discussion. With this, we come to end of the all panel discussions. Now I welcome Gunjan Tanwar for the valedictory session. Gunjan is a student from the postgraduate program. She's also the Vice President of Healthcare Club, Mohali Campus. Thank you, everyone. Welcome, Gunjan. Over to you.
Thank you, Mr. JP. I would now like to introduce Professor Sarang Theo for the valedictory session of the HealthScape event tonight. Professor Sarang is the Professor of Operations Management and is the Executive Director of Max Institute of Healthcare Management at ISB. Professor Sarang is interested in investigating the impact of operation decision on population-level health outcomes. Some of the healthcare contexts that he has studied include the influenza vaccine supply chain and the phenomena of ambulance diversion in the US. So over to you, Professor. Professor, you're on mute.
Yeah, hi, good evening, everyone. Thanks, Gunjan, for the introduction. And thank you, everyone, for staying around in this so-called graveyard shift. We are towards the end of a long marathon event. I was just reflecting on this. This is Friday evening, and people are just catching up on post-COVID enjoyment. The pandemic is behind us. So to have about 100 people, around 100 people still here after many exciting sessions is also an indicator of how interesting, important, relevant healthcare has become for a wider audience. I was just thinking about 2017 when the last national health policy was released. And if you look at that document now and look at where healthcare is today, I don't think the difference is only the pandemic. A lot of other things have happened. Without the pandemic as well. Ayushman Bharat happened. The National Digital Health Mission is happening. Startups have happened, even pre-pandemic. The healthcare sector in India today is not the same as it was 5 years ago. And no one should be surprised if 5 years from now, the health sector in India is very different from where it is today. I'm imagining that that change will partly be because of some of the people who are currently in this event. That's the hope. The other thing I was reflecting on was just a few discussions I've had with different stakeholders just in the last week. To give you example, we've been discussing with a state health commissionerate who's very keen to design a value-based care program for NCDs. Right? So imagine now a state health commissionerate engaging in a conversation about value-based healthcare for non-communicable diseases, which has always sort of gotten a step-sibling treatment when it comes to infectious diseases first, then we'll deal with lifestyle. That's one example. The other example is we are discussing with a state government how to transform about a 6,000 bedded hospital attached with their medical college. Right. So again, medical college, you can imagine who the people running that hospital are, and yet there is appetite to do a large scale operational transformation. And the third discussion we had just today is where a major business sort of management consulting company is working with a large international donor to create, and this is very complex for me to even explain, so let me try, okay? To create a self-sustaining platform where private and public hospitals can avail of technical assistance from expert delivery organizations. And this technical assistance could be creation of group purchase organization, services of tele-ICU, availability of specialists, so pooling of capacity of super specialists, so on and so forth. All of this is telling us that we are slowly transitioning in our healthcare sector from what I like to call, and I've said this many times, like a cottage industry thinking, to something closer to industrialization. We are not yet in Industry 4.0. It's a good label, but I don't think we are there yet. But there are signs that we are getting more organized. But as they say, abhi Dilli dur hai, right? So these are all good changes that are happening. But there's a lot of uncovered ground. And I use that term Dilli dur hai for another reason, which is, the uncovered ground is far from Delhi. So if we want to really see the changes, experience the changes, lead the changes, we got to move beyond the north and the south block in Delhi. A lot of the action is in the states, is at the district level. So with that preamble, I wanted to put out 2 or 3 things that constantly sort of come back as insights or ground truths when I interact with people, different stakeholders. And I'll try to connect to the panel discussions that have happened. One, we keep saying technology is an enabler, right? But let's just say it and understand what it really means. A lot of us are, technology native people, right? We naturally understand how to do things using technology first. But that may not be, we have to sort of not get enamored by technology alone. I have found personally that very few stakeholders truly incorporate this statement in their strategies, and even less so in their tactics. For example, in the private sector, when we ran this small survey of medium-sized hospitals, the one thing that struck us was while a lot of hospitals, even in tier 2, tier 3 cities, are keen on technology adoption, they don't have a technology strategy. And when you sort of dig deeper, they don't have a business strategy coherently defined to begin with. And we've learned in management that technology strategy will flow from business strategy. And then when you go one step further and say, okay, what are these hospitals competing on? Because if technology is an enabler for competing better, what are they competing on? And you have to draw a blank because, in most local healthcare markets, the competition is possibly just price. There's very little differentiation in terms of service and clinical outcomes. So one has to keep that into account as we talk about technology being an enabler. In the public sector, and talking about the National Digital Health Mission, there is a very similar situation where if leadership in different state governments are not clear on outcomes that are of primary interest in their state, it is quite likely, and there's a real danger, that the National Digital Health Mission may end up becoming a registry of doctors and hospitals. It's the first step. There's no question. Unfortunately, we don't have a database of all hospitals and all providers today. It's needed. But it can very well become just that unless there is from the beginning an explicit connection between that and outcomes such as infant mortality rates, maternal mortality rates, hospital-acquired infections, so on and so forth. Then we can ask, what do we need technology for? A corollary of that, and I think this has been covered in some of the panel discussions, is technology transformation needs to be accompanied with at least process transformation and people transformation, right? Where are we going to use this technology? So strategy is okay, but which processes? The last panel discussion itself talked about clinical, non-clinical processes, patient experience processes. You can't create new value with technology unless you fundamentally change how you do something to your patients, to your customers. People transformation, I think, is equally important. We like to blame engineers and data scientists for not understanding health, but I think half of the blame has to be also placed on healthcare people who want to become data engineers and data scientists. And so you have to kind of curb the enthusiasm there and say, no, you don't need to learn AI and ML. But what you need to do is learn how to ask very difficult, very stupidly simple, but extremely difficult questions of those engineers and data scientists, because that is what will then get them going on the right as someone was saying, right algorithms, right platforms, right infrastructure for technology, etc. But the questions have to come from clinicians, have to come from healthcare people. So that people transformation. So that's not technology orientation. That's just, again, fundamentally asking, what do I do? For years and years, thousands of years, we have understood one mode of delivering care, appointment, or one patient and one provider, right? Either physically, and now we are saying virtually. But some of my students know this. Can we fundamentally change this and get 10 patients in one room with one doctor? What does that mean? Unless we think dramatically differently, we may just keep on repeating things that we've kind of done before. The last bit of transformation, again, I'm maybe saying most of the obvious things, is the technology, the processes, the people all have to be embedded in some sort of a business model. And I'm hoping that there has been a lot of discussion about how hospital is a business model, right? I mean, forget about different models of hospital, but hospital itself should be one small component of a healthcare delivery system. I hope many hospitals are thinking, how can we, obviate our need, but then transform into something else. For example, in the US, there was a big discussion about accountable care organizations. And one of the hypotheses 7-8 years ago was that hospitals would be very poor accountable care organizations. You need a completely different organizational structure. We need to think along those lines. And again, our research shows that that's where a lot of innovations, both on the technology and the process side, fail because they do not get embedded in a larger business model, which is quote unquote sustainable. We can show that a certain model gives better clinical outcomes, but who's willing to pay for those clinical outcomes? So there, my sense is that unless we have a drastic change in financing of healthcare, who pays for healthcare and how do they pay? Currently, we are, paying at the retail point. Like it's like going and getting a vegetable or getting a consumer good. We go and get some healthcare and pay over the counter. It's unlikely that we will be buying value like that. Yes, state health insurance schemes and Ayushman Bharat probably is a movement in that direction, but some of us need to change the discourse from package rates, either as providers of package rates or buyers of package rates, to something different, something more focused on value. And the last thing I will say on value is, again, our recent recent work is showing that we cannot transplant ideas from other countries when it comes to value-based care. When it comes to, for example, one recent example is how to reduce antimicrobial resistance. There are discussions about delinking revenues from sales volumes. That makes a lot of sense in developed countries, okay, where you can keep track of how much is being bought, what are the incentives. In a decentralized, fragmented system such as India, what does it mean that if I'm buying one strip of Augmentin, then I don't pay the price unless my infection is completely taken care of, and then I go back to the pharmacy and pay? So we will have to fundamentally rethink some of these ideas that come from outside in terms of new business models. I'll stop here. I know we are running out of time, and some of these thoughts were not meant as being pessimistic, but to provoke more thoughts and possibly some innovation in thinking. Thank you so much again for a wonderful response, and thank you to all the panelists, all the speakers, my colleagues, moderators, and the staff and students who've made this a success. I know there's a formal thank you that's going to happen afterwards, but I must do it on my behalf as well. So thanks all of you. Thank you again.
Thank you, Professor Sarang, for such a valuable insights and your valuable thoughts as well. Now I would like to hand over to Ms. Vandana Yadav for the vote of thanks. Ms. Vandana Yadav is the manager at ISB and leads the outreach and co-curricular learning initiatives at MIHM and has run the entire HealthScape event from ideation to execution. Over to you, Vandana.
Thank you, Gurjan. Good evening, everybody. I hope you've all enjoyed the deliberations we had today on next generation business models in healthcare. I know it's been 4 intense hours of discussion, so I'll keep my bit very short. It gives me immense pleasure to propose the vote of thanks today, because this feels like the culmination of almost 2 months of our concerted efforts with the students of the AMPH and PGP at ISB. So thank you, class champions of the Advanced Management Program for Healthcare, JP, Shilpa and Smita, for taking time out from your work as well as studies, because we know that you're all working professionals by the day and students by the night, and yet you found out time to curate and coordinate the respective panels. So I think this is what we truly call being back to school. I would also thank the students of the PGP program at ISB and Healthcare Club leadership, Nipun, Gunjan, Sriram and Praveen, who have in between their crazy classes and assignments found time for curating the event. At ISB, we persistently strive to teach our students the power of collaboration for the larger good. And I think ISB HealthScape is a perfect example of how 2 academic programs came together to weave engaging discussions on the latest trends in the health sector. I would like to thank my colleagues and the leadership of Max Institute of Healthcare Management, Professor Sarangdeo, Dr. Ashish and Soumya, whose constant guidance has helped shape up the entire event and the discussion topics. And of course, Mehek, who has supported us with seamless coordination and execution for the conference. Lastly, thank you to our outreach partner, the AMPH admissions team and MIHM team for their outreach support, and the fantastic ITAV team who for running the entire 4-hour-long conference glitch-free. So I think with that, we can safely call it a night. We'll be in touch with all of you who joined us from across the world, and thank you all for joining. But before we close, I would like to invite the team HealthScape to switch on your cameras for a group picture. Shilpa, Mehek, can we have your camera switched on, please? Everybody. Thank you. Say cheese. Thank you.
Thank you. Thank you, Vandana.
Thank you so
Bye,
much.
everyone.
Good night. Bye.
Good night. Thank you.
Good night. Thank you, everyone.
Okay. Bye-bye.
Take a pic like this, no?
We're done.
Thank you.
Bye. Thank you so much. Good night.
Good night. Thank you.
Good
night, guys.